Depends on the jobs.
Okay, good morning everyone, and thank you for coming today. A lovely sunny day in Somerset North, and I don't know if we have any members of the public, but welcome. I'd like to, obviously I'm Jill Slocum, I'm the chair of the Adult Scrutiny today. The agenda pack with papers is available via ModGov or directly from the council's website from the link which was sent out to members. In line with the recommended meeting procedures, I'm requesting that all members and officers turn off their microphones and videos, but please remember to turn on microphones and videos when you speak. This helps the background noise, call quality, and anything that might disrupt the meeting. When I invite somebody to speak, could you clearly state who you are for the benefit of anybody who is listening to the meeting? They can identify who is speaking. Can I also remind committee members to use the chat function solely for otherwise it's distracting. If there are any questions or conversations happening, can I warmly welcome any members of the public and media also join us today. Finally, as agendas are now viewed electronically, could I kindly request that members and officers refer to page numbers from the published agenda pack to assist all present in finding the appropriate information. So item 1 is apologies for absence.
We've had apologies from Councillor Osborne, Councillor Carlstone and Councillor Robin.
Are there any others?
Yeah.
Hold on. So item 2 is next meeting on page 20. Item 3 are declarations of interest. I invite those who have any interest in making the list of meeting members' personal interest and members of the town and council is available in section 1. Nothing other declarations. Item 4 is public question time. At this stage there are no questions submitted. Item 5 is page 21, 28. This is the work programme. This is having a new item to the forward programme, which is really to go back into the meeting. Can you hear us online, everybody? Thank you.
No, we can't actually.
I'm terribly sorry.
Chair, the sound quality is awful since it had some feedback.
Oh, that's Graham's fault. We'll sort Graham out later.
I'm just going to come on. I'm just going to leave that.
Yeah, Graham's going to come out. I don't think. I'll just check mine as well.
Yeah, let's take it.
Oh, just don't
I'll
want it. I'm gone. Is that better?
Is that any better?
It is actually, yes. Yes.
Well, Graham is here, but he's not here. Okay. Thank you very much. Oh, Councillor Lawrence. Could you use your mic, please? Sorry.
At some point in the future, look at homelessness for over 70s. Sleeping. This summer. Seems as if there are a number of these.
Yes, I think it might be that we get a briefing done on it first, and then we can. Oh, I beg your pardon. Councillor Lawrence is just asking for homeless and rough sleeping to be brought to the committee or have a briefing on homelessness and rough sleeping for the over 70s. Obviously, this is a very important issue, and it seems to be a growing problem. So we will put that on the board plan. Sorry, I've just got hand over to Matt.
What we'll try and do, if it's appropriate, is we'll do something around homelessness stuff I don't know where we've got all the age bands. I don't know the information about it. But we'll have a look at that and then we'll try and work it through for you. But we'll do that.
Thank you very much. It has been a real worry this year.
Item 6 is the 23-24 budget overturn, and I'd like to invite Penny Gower to present. I'm so sorry. I said that the last time, Christian, so apologies. So now over to Christian.
No worries. Thank you, Chair. Morning, everybody. So my name is Chris Evans. I'm head of finance business partnering. So you have two reports agenda. So one is for the actor. Fine. So just an overall view. So the provisional outturn for the council is currently showing £1.6 million underspent. There are large overspends and all the other services that the budget has come in under, which is good news. There's significant investment involved. But going back to the outturn 23-24, so net budget for our services was £190.8 million. That's the overspend is currently 17.9% of the budget. That would have been considerably higher. Main issues have also compared to the residential and nursing, so the costs higher than maybe standing exercise.
Sorry to interrupt, Chair, but I can't hear a thing at this end online. It's John Bailey here.
Terribly sorry. We'll just stop the meeting for one moment to see if we can get the sound sorted. Could everybody in the room, could they make sure they turn off their sound on their computer, just in case? Everybody turn off your sounds.
Christian, move the mic down.
Yeah, is it easier? Is that better?
No, move it nearer again, nearer again. They're all brand new batteries in.
Yeah, is that better? Can you hear me online?
Can you hear?
Can you hear me online?
Yes, I can. Yes. Oh.
Anybody hear us now? Hello?
Yes.
Yes, I just heard that.
You can hear me? So we're going to test Christian again.
Hello, can you hear me online? Hello? Can you hear me online? Yeah.
Yes, you do sound like you're in a fishbowl, but it's bearable.
We just swap over the mics. Would that be perhaps a good idea? Just swap over the mic. Maybe that'll. They had brand new batteries in this morning, but
Let's try this. Good. Hello, can you hear me online? Is it clear? Is it better?
Yes, thank
Much
you. It's John
better.
Bailey here. Yes, thank you.
That's lots better, I think.
nearer to the box.
Yeah.
Bring the box near. Oh, I know that. I know it sounds ridiculous, but we've had this before. If you bring the box nearer.
Is that it? You can hear me online clearly, yeah? Hello? Yeah?
Lovely.
Right. Try again.
Thank you.
Okay.
Sorry about this. Thank you. If you can start again, Christian, that'd be all right.
Yeah, so going back to the medium-term financial plan 23-24, there was over there's over £10 million worth of savings built into the budget. So my life, my future. The anticipated savings have been brought forward, or the main amount of them are brought forward into 24-25. So 3.9 million of that was unachievable last year, but that was early on in the programme we realised that was going to happen, so it's been brought forward. The remaining savings have all been achieved, which is good news. So the use of disabled facilities grants to fund equipment, that's been achieved. The Better Care Fund, integrated care board funding, that was also achieved, as well as a community-focused redesign. So again, good news. From the month 2 perspective for adult services, so the net budget was significantly increased from 23-24 to 24-25. So a lot more work by Penny and Mel and the team, which meant an increase of £59 million on the budget to £239.6 million. Currently predicting a £1.7 million underspend. So that's extremely good news. The costs of bed basically are coming in below the budget figure at the moment. So there's still significant pressures on the budget, certainly within mental health and learning disabilities, and quite a lot of pressure to deliver the savings for my life, my future. And then from a tracking perspective of 24-25, you can see there from the medium-term financial plan for 24-25 that all of the savings, the £13.7 million, are either achieved or on track. So that again is very good news and very good work by obviously Mel and the team. So happy to take any questions on all of that.
Thank you very much for that, Christian. It is a bit pleasing to hear some positivity. I think we need a lot more positivity on the budget, definitely. But it's hope we're going in the right direction. Do I have any questions from members? Councillor Lawrence.
Thank you. Very helpful report. I enjoyed reading it and looking at the greens. But my concern is for the future and the budget setting for the following year and the year after that, with increased pressure on numbers in the community that will need help, because we are all fortunately living longer and we all need help at some time. So my concern is not immediate, but in the longer picture, what can we be thinking of doing that will help us in the next 18 months and beyond? Because I think it's a thing that we ought to be thinking about sooner rather than later. Thank you.
Councillor Wakefield.
Yeah, I can certainly answer some of that. We are doing a lot in the team to keep people at home for longer. It's re-ablement, it's extra skills, and we are doing that through the My Life, My Future programme, but it's also part of what the team is committed to doing. And actually that is really having an effect. We are now finding that people are able to stay home. We've got the Somerset Independent Living Centres, which are really helpful to people if they need support at home, or if they need, their relatives need to be sure that they're safe at home. I mentioned this, I think, at the last meeting. I recommend anybody who's got a relative or friend who needs help and support, and just a bit of oversight of what they're getting up to. You can do that through some of the tech we've got at the Somerset Independent Living Centres. So I think, personally, I would say that some of the activity that we are working on in the team to bring people or to keep people at home for longer is really paying off in terms of the costs to the budget. I do also want to say, while I've got the microphone, Jill, that I want to thank the team and including my predecessor in this role for the work they did last year. The budget was reset completely in order to come up with the additional 59 million, and that has made a huge difference to how we feel in the team about whether we can stick within the budget or not. And unfortunately we weren't able to do that work before the first budget of the new council, but going forward we are more confident that we have a handle on where the money's going. We've got the peer reviews going on, and the enhanced peer reviews, so we look at where the money is being spent and we challenge our staff when they're trying to make assessments and placements. So I think a lot of work is going on, and I'm confident that this work is really paying off. But I'm sure others can say things on it too.
Ma'am, do you wish to say?
I think the other challenge is we don't know. We all know that how we fund health and care for the future is still up in the air. And I think what we will do is wait to see what a new government brings in that space. But what we do know is we have, for the first time, got a really good, solid start to the year. I don't think in all the time I've been here, I've not started the year with an overspend. So this year we've started the year with a balanced budget, and that's really, really good. I know it's taken a lot of money and everybody wondered why, but you will see that this budget will work for this year. We've got a new model of delivery. We know now what we need in the budget. We just need to keep going with that. There are questions, and there are questions around next year. What does the living wage look like next year? I don't know the answer to that yet, and that impacts on our care providers. So there's things that will come up that we're just going to need to work with this government around how do we have a proper way of delivering and funding care going for the future.
Great.
Can I just make the general point that maintaining people in their own homes, supporting them either with family members, which is the vast bulk of the case, or with home care is a brilliant thing. However, year on year, the needs of the people going into care homes are greater, and the costs of looking after them will increase. So whilst you will see more and more increased costs going in initially into the Zombie Care budget and putting that under pressure later, maybe this year, maybe next year, whatever, there's a rolling effect later on that the actual costs on residential cannot be controlled in the way that they're being controlled at the present time. The department are doing an excellent job of damping down demand on fees, but that's only sustainable for a period because of the fact that when people come in who need a lot more care, you do have to provide those staffing. So members need to be aware that later on there will be another uplift again because it's fairly level on a lot of the fee side over the last year, but that's the world we're in.
Thank you, Councillor Oakes. Councillor Woods.
Yeah, I think in the current year we've had some funding from the NHS where you've got people coming in from hospital. Is that continuing as we speak, or is that run out?
So last year we did have a bit of one-off money from our ICB. That was one-off money, so no. But we have a pool budget for quite a bit of our work. So yes, none of that money will change. So our pool budget around learning disability, our pool budget around carers, our pool budget around equipment. But we work as a system, whether that be with our partners that are here today from our acute and community services, whether that be our ICB. So we are a system and we do move money around that system, and we'll continue to do that to make sure the needs of people are met.
Thank you. Thank you. Bruce.
Thank you, Chair. A slightly vague question, probably for Mel, I think. It's great to see that the savings have been achieved and that we're on track for more savings. Are there any areas that have come up during this time that are flagged up as a risk from those savings that perhaps we hadn't identified in the past, or anything that we need to be aware of from that?
So within the budget we've currently got, I think we're as good as we can be. There are always risks, and there are three risk areas for me. One is around depleted funds or capital drops, whichever way you want to call it, where people go into care homes quite early on, probably earlier on than we would expect, because that's what families do, and they run out of money. So that we are seeing more and more people end up needing our funding. So that is a risk area. We've made some provision for it, but whether we've made enough is always the debate we have. The other risk area is around international recruitment. So one of the reasons why our care home prices are levelling out, one of the reasons why we can manage home care in a very different way, and there's a lot of home care, is because of international recruitment. You will also know that the law changed in international recruitment that they cannot now bring their spouses, whether that be for us or for the NHS, it's exactly the same. And that may, question mark, I don't know what the impact of that's going to be yet. And so that's our other risk area that isn't in our budget that we currently have. I think the other areas are, does the new government change the way in which we are delivering? Do they ask for different things? And is that funded? So they're the three risk areas. Currently, I think we've managed as much risk as I can, but this is a demand-led budget. And that's always a question for me.
Thank you very much, Mel. Thank you. I have been doing a little bit of digging as well, and I'm going to bring this up on item 9. So it's not too, but I personally have found some areas where, as a scrutiny committee, it's good for us to be able to find areas where we think things could work better or for savings as a critical friend. So I think I'll leave that to item 9. Is that okay? You've got that to look forward to, Mel. Thank you. Right. Okay. Thank you very much, members. Thank you. We're now going to, excuse me, item 7, which is the CQC reports on maternity services in Somerset. And that is Sally Bryant and Andy Heron. So over to you.
Thank you, Madam Chairman. I'm delighted to be joined today by Sally Bryant online, who's our newly, very recently appointed Director of Midwifery for all of our maternity services across the county. And also, I'm hopeful, yes, there she is, Dr. Claire Lovelock, who is also recently appointed one of our most senior doctors, clinical director within our maternity services. I wish I was here, members of the committee, to talk about many of the excellent services, any of them that we run across the county in our acute services, our community or mental health services. But today, unfortunately, I'm not. I'll take the report as read, but as you will see, unfortunately, an inspection, a planned inspection by the Care Quality Commission in November of last year of our maternity services at Yeovil District Hospital, at Musgrove Park Hospital, and also at the Mary Stanley Birthing Unit at Bridgewater Community Hospital, found that our services at Yeovil and Musgrove were inadequate, and that our services at Bridgewater required improvement. So this is an area where, unfortunately, we have obviously fallen short. And you may have seen from some of the media coverage that came out at the time, we've been very keen to apologise to the families in Somerset, to the public in Somerset who rely on our services. As we've obviously come up short at this point, also to apologise to our hard-working staff. And even within these inadequate reports, there were many, many good things said about the caring attitude of the staff and about team working within those services. I suppose in the end, there are two ways to react to a report. You can sort of be fed up and think it's unfair and go into some kind of denial, or you can embrace that report as being helpful criticism and a tap on the shoulder that we need to do a great deal of work to improve the quality of our maternity services, and in some very specific ways that were highlighted by the Care Quality Commission. So I'll just say a little bit in overview about the actions. The reports are there for everyone to read, and they, of course, are on the Care Quality Commission website. So this matter now public record. But I think people in Somerset, the families we serve, would probably be very interested to know what we're doing in response to that. By the time obviously we got a heads up, and we got the report ahead of formal publication. So actually, by the time that the report was published, we had already made quite a good start on changing things within our maternity services. So there is now a weekly. We've just actually moved up to a fortnightly because we're making good progress. Maternity and neonatal action group, which is co-chaired by myself as chief operating officer and deputy chief executive of the trust, and my colleague, our chief nursing officer. Also on our cast list, in addition to my colleagues today, many other senior colleagues from the service. We're joined at that meeting by our chief medical officer. So that's unusual for all of us. We run so many services, and it's unusual for all of us to be so focused on the service. But I think that's a measure of the gravity which we're giving this report, the things we need to improve. So I've got, I'm fortunate, very fortunate here today, having Sally and Claire there to maybe respond to any detailed question that members of the committees might have, but just to give you a flavour of some of the things that we are doing. So in response to the report, we've strengthened our governance processes in many, many ways, and that's an ongoing process. Where we're now seeking rapid learning cycles and continual improvement in the care that we deliver. All guidance and policies that were highlighted in the report have been reviewed and updated, and we've got increased now scrutiny and governance around our policy processes, ensuring that these are available to all colleagues who need them. We've reviewed and mapped all mandatory training. So you may have noticed one of the points highlighted in the report is that we were not on track with, there's a huge amount that we need our colleagues to do to stay up to date. And unfortunately, we'd slipped behind with that. But we now have a very intensive programme of training and are making excellent progress in catching up with that. At Musgrove Park Hospital, we've also put in place a new evidence-based standard triage process. Of course, triage being really the way that we prioritise the urgent work that we need to do on any given working day. And a lot of work's now going on to embed that on a very firm footing and for that to be a new approach to how we prioritise the work of the day. I'm sure Sally and Claire could talk much more about that if that's of interest. And of course, we did have the required equipment that you need to run a modern maternity services, but part of what CQC found was that they wanted to have more of some specific items so that they were sort of more rapidly to hand, a sort of better ratio between the sort of number of beds that we have. So we immediately purchased that equipment, and I can assure the committee that the money is not standing in the way as an obstacle to improving quality and safety in these services. So that's a sort of, we've got ambitions to go beyond this, to move from these positions of being inadequate, whilst we're improving. Of course, we'd like to aim for outstanding. Some of our services in Somerset are already outstanding. We know how to do that. We know what it takes. We have a brand new, really top-notch leadership team in place. In many ways, the timing was very unfortunate for us because we were going for a new leadership team anyway. The report, the inspection came at a time of transition, but nevertheless, it found what it found. So we've got huge confidence in our leaders now and the work that we're doing. And I think we're making excellent progress. And we've got a lot more work to do. And so complacency would be the enemy here. So that's probably enough for me. I'm very happy to take questions, or if I can possibly deflect them to my colleagues who know a lot more about this subject, and I'll do my very best.
Thank you. Just before I go to Grant, I just wanted to say, Were you surprised by this report? I mean, did you assume that everything was okay? Had you, because I know, especially at Musgrove, it's an old building. I mean, dare I say I had my children there, so, that's some time ago, not long ago, really. But you know what I mean? It's an old building. I wanted to, did that make was that part of the issue or not at all? Because we need to make sure that mothers have confidence. We need to make sure that, in both hospitals, especially.
Thank you. So we were not entirely surprised. We thought we may be in line to for requires improvement. We actually, I mean, in talking today, what I don't want to sound is as though I'm making excuses, but actually we were slightly surprised to receive inadequate, because we consistently get so much positive feedback from families that are using the service, and also our clinical outcomes are good for the services. But I'm glad you mentioned the building. The buildings for our maternity services at Musgrove Park Hospital are pretty awful. They were originally built, I believe, as temporary buildings during the Second World War. We are officially part of the new hospitals programme, and so have highly developed plans to develop quite a lot of the site, but our maternity services have been number one priority for quite a long period of time. But in all honesty, the condition of those buildings, the configuration of those buildings, and as you have seen from the report, part of the criticism of the service related to the quality of the estate, really work against our teams in trying to deliver modern and best possible care. So our campaign and our hope to get confirmation of funding and a date when we could rebuild these services goes on. But in all honesty, yes, they are a really important factor, but they're definitely not an excuse.
No. But what we must do is make sure that all the staff are given the confidence that we want to make sure that they're doing a good job, and it mustn't reflect on them, because this is very difficult for them, isn't it? So, Councillor Oates.
Thank you. My daughter was born at Musgrove, and I will also share that I've carried out inspections for companies not in hospitals, but the equivalent of CQC, and some of the best care is delivered in some of the worst buildings. I think you need to move your thinking away from the buildings. What the report shows is a series of leadership failures, and you had the wonderful opportunity of 2 days' notice, which is a rarity. I've never actually had notice of an assessment, as I know called. Could you tell me how the 2 days were used?
So for a planned visit from the Care Quality Commission, there are very significant requests for information, records of audits, etc. So in preparing for the visit, our teams were getting all of that information together, also running last-minute checks on our services. But as you will have seen, the shortfalls that were found by the inspection were mostly related to systemic issues. And I would agree with you, leadership failures on our part, and they're not things that can be fixable in 2 days, or obviously that we would ever seek to hide. So usual preparations went on, but the fundamental points that were found on the inspection, most of them are actually more systemic things that have become problematic over quite a period of time and are taking some time to fix.
I do have Councillor online, but I'm going to go to Councillor Wakefield firstly.
Yes, thank you. I did read these reports. I particularly looked at the one at Musgrove Park, which is where my last child was born. I just want to say one thing about the regime. I'm sorry, this affects us as well, because in adults we're going to have a CQC inspection. I do not accept that inadequate is a sensible word to use. I'm sorry, there are people having children there and midwives working really hard, and I would not accept that inadequate was the right word. I think requires improvement is fine. And you could say that some areas weren't working well at all. A lot of it was book records. As you said, some training wasn't up to date. But on the doorstep during the election, I met a midwife and she said, I can't tell you how upset I am about this. We all work really hard. We have people nowadays who turn up in labour with absolutely no hospital record and no prior knowledge for the hospital. It's really difficult to deal with people in that situation, some of whom English isn't their first language. It is really difficult for the staff in those situations. I think that the word inadequate is so unfair because if you were told that the car you were buying was inadequate, you wouldn't buy it. So are you expecting people, having got this record, to say, oh, I'm not going to any of those hospitals because they're inadequate, I'll go somewhere else? That's not an option. I don't think it's fair on the staff, and I don't think it's fair on the system either. I'm sorry, but I think requires improvement is the lowest grade, really. Having said that, I do worry about the staff and how the effect on them. And I think that I just wanted to ask you whether you have been able to reassure the staff. Have you been able to, I think recruitment is a problem as well. I don't think you mentioned that, but midwives are retiring and the newer ones probably don't have the same experience. And it is a lot of hospitals I know are having difficulty recruiting enough midwives. And that puts the ones who are there under even greater pressure. Which means sometimes you just have to slightly do something not quite as well as you'd like to do it, but in order to get to the next patient. So perhaps one of your team would like to comment on that point about staffing.
I'm hoping Sally.
Sally, can we have a response, please, if that would be really appreciated.
Of course. Can you hear me okay in the room? Excellent. Yeah, yes, thank you. Sorry, I could hear you saying something, but I couldn't hear. Can you hear me? Yeah, louder. Okay, sorry. I'll try to lean over the chair slightly. Sorry. So absolutely, it's been one of the hardest things to manage, to wrap around our staff through this entire period. We have been really fortunate on the entire journey to be working really closely with our maternity and neonatal partnership, MNVP. This is a service user group who have been involved with us for 6 years now, working with us to co-produce our services. They have been intrinsic in helping us manage the support for our staff and for our service users and their families as we go along. Oh, sorry, poor sound. Do apologise. Can you hear me well enough to hear what I'm saying?
We did manage that, but it is really difficult. So if you could, like I said, you're just sometimes going off.
So sorry, I don't really know why it's doing that. I'll just try and lean a bit closer. So our MMVP worked really closely with us. What we can say is that during the entire period from the publication of the reports to now, we've only had 4 families come through our PALS department with concerns and asking for reassurance around the safety and quality of our services. And what we're also hearing from the staff on the shop floor who've read the reports is, this doesn't sound like my service. Those two things combined and supported by our service user voices group have worked really well together to reassure both staff and service users. We've increased our communication with service users and staff as well as a team, guided by our MMVP as to regards to the language that we're using to support our families to feel safe coming into our services to have their babies with us. And we've had continual communications between service users and staff as a leadership group to keep them up to date with some of the changes they've seen. I absolutely take your point. It's very difficult for staff working in these services to carry on delivering the care they're delivering and turning up to work every day and every night when there is this kind of inadequate label. It's really difficult, and it is, as you say, difficult to recruit staff. We're fortunate that we haven't had a challenge recruiting midwives in Somerset to this point, but I suspect with the way that the national midwifery shortage is heading, it probably will hit us. So it's incredibly important that we work on improving our ratings so that we can attract good quality staff. And I know that Claire will agree, one of our main challenges at the moment is recruiting obstetricians into our workforce. Again, there's a national shortage of qualified and experienced obstetricians, and it does make it more challenging to meet the needs of our service. But our main priority through all of this, as well as doing the work that we need to do in response to the CQC, is supporting our staff and our service users to continue to deliver high quality and compassionate care day after day.
Thank you very much.
I would also say that I think as a new leadership team, a multidisciplinary leadership team, that has really helped as well for staff to see that, you know, midwives, obstetricians, neonatologists are coming together to solve this problem.
That's really, well, I mean, that is really good news to hear, I've got to say. Thank you for that. Right, I'm going to go, I will come back to you if I may, if we can't get all the answers. So I'm going to go to Councillor Bailey, who's online, who is a committee member. So that's why I'm going online. Councillor Bailey, can you speak up though, please?
Yes, can you hear me okay, Chair?
Perfect.
Yeah, the question I've got really is that I can't find, having read through the report, and obviously we all want to make sure that they've got the top class in terms of maternity services, and I fully understand the impact this would have had on everyone in the organisation. But it's not my area of expertise. But what I really wanted to see was an action plan that was at the end of the report, which would focus on the key areas that the leadership team had prioritised, and also decided where the resource were going to be focused and the timescales over which they were going to do things. I'd like to see that, because I want to be able to go out and talk to people and say things are being done, and give them the confidence, and give me the confidence that things are improving, but also allow us to, as a scrutiny committee, to monitor that things are improving that general direction. And everybody concerned has expressed how concerned they are and what they're doing to improve things, but I can't quite see it through an action plan. There's a lot of areas in there, but where the time and effort's going in terms of resources, would it be possible to have an action plan which really trims out and focuses on the priorities, and something that we can come back to and talk about and pass those on to people with an air of confidence? So it's the action plan area I was hoping to see.
Yes, thank you. I think that's something we were going to ask for, so thank you for that. I think, can I go back to you, Sally? Would you like to comment on that, please?
Yes, thank you, Chair. Happy to. We do have a really detailed and robust action plan that we are more than happy to share. We've just had our first formal review of the action plan, and we have a follow-up meeting with the CQC next week, I believe, who we're meeting with regularly to update them on actions taken and giving them details on the prioritisation of the work. But we're more than happy to share that detail.
Thank you very much. That's something we really do want. I mean, you know, we were going to ask for a briefing or come back in 6 months anyway. So we really want to keep on this, and it's really good that you've got the CQC coming back. So that might give you a totally different view on that. I'd like to go to Councillor Lawrence, please.
Thank you. Just want to ask about staffing. Are you short-staffed or are you fully staffed? Because obviously a lot of this depends on having the right people available at the right time in a very pressured area. I know the staff you've got are working extremely hard, but I do understand that there is a shortage of midwives, and I just wonder how Somerset stands in this situation.
He's asked the question from the chat.
Thank you. I'll respond if that's okay. We currently have no midwifery vacancies at any of our sites. However, we are going through what's called Birth Rate Plus, which is a workforce modelling tool, which will give us a more up-to-date, contemporary recommendation for the number of midwives and maternity support workers we will need in service. We predict this will recommend an increase in staffing, because the services we're now delivering are quite different to those that we were delivering when we had our last workforce calculation, and that includes the new triage service that we're now delivering. So on paper we have no vacancies, but we are likely to have vacancies in the future, and we already are very pleased to say, for midwives at least, Claire will tell you a slightly different story of obstetricians, but for midwives we have people making contact with the service quite regularly asking if we have vacancies, which is fabulous, because despite the inadequate rating, our reputation is still good amongst colleagues across the South West, So we are still attracting midwifery staff. I'll let Claire comment on the obstetric workforce.
Currently, we have 3 consultant level vacancies for varying reasons, one of which is being covered by a long-term locum, another which is a short-term locum, and then we're all flexing between us to cover any extra gaps. We've also got some gaps in the registrar level as well, for which we are recruiting locums for, but that should hopefully improve in August when we get our new trainees through from the deanery. We should be up to full complement then. But yes, it is a significant problem actually nationally, recruiting obstetricians.
Well, it's good to hear that the vacancy situation is good. That's excellent.
That wasn't very clear, was it?
It wasn't very clear. You're not as clear as your mate, Sally. She's a little bit clearer. She might be nearer the microphone bit, but I think we've got it. Can I So can I just go to Ashley Richards, please? Can you please make sure that you speak really loud if that's possible?
Hello, can you hear me?
No, I'm sorry, we can't. You sound like you're swimming.
Oh, right. Is that any better?
No, it's not. Right, so what we'll do is for you, Jenny Murphy will ask your question that you put forward and we'll get the answer. Hopefully you can hear okay, and that will help. Okay, thank you.
So in the chat, Councillor Richards has asked, what are the systemic issues that affects the staff to deliver adequate service?
So, Sally?
Thank you. I'm hoping you can hear me. I apologise, Claire, I'm leaning right across you. So the systemic issues certainly relate to our governance, and at the time of inspection, quite a significant lack of oversight around things such as our appraisals and training and guidelines in and out of date, things like that. So as Andy described earlier, we've focused a huge amount of effort on completely reviewing all of our governance and redeveloping our governance processes, and we're doing things very differently now. It is a journey, and I think every time we review what we've done, we learn something new, and we go back and we tweak and change. But we now feel we have really clear oversight of where we are with things such as our guidelines being in and out of date, our training compliance, and sharing the information around our safety outcomes the way it should be shared, and taking the learning from that. And I think that was probably the key theme to what led to an inadequate rating, if I'm honest.
Thank you very much. I hope that's you've heard that well, Councillor Richards. And obviously, if your sound improves, please put your hand up again, and we'll try to get you again. Okay. Councillor Martin Wale, please.
Yes, good morning. Mine is a rather localised question about maternity. I was in our local child community hospital the other day, and I was rather surprised when going upstairs to find that the wards have been converted into various units, very, very useful, I must say, and one of which is a maternity It's in the maternity outpatients, but it is obviously relatively new to my knowledge, and very, very welcome. And I just wonder if this is being pushed out to other community hospitals in the area, because locally it will be very welcome.
Thank you. I don't know which one of you wants to answer that. Sally, can you answer that, or Andy? One of you?
Yes, I can answer that. So the Chard Hospital houses our Chard and surrounding area community midwifery team, who took up residence there, I think probably almost 4 years ago now, and took advantage of some space that we were not using for other reasons. And it has grown into a really, as you say, thank you for your observation, a really wonderful hub. And it's in a really opportunity area for us, because a lot of the women in that area will either access Musgrove or Yeovil services. So it has certainly supported our integration as we merge trusts across that particular area. We do have community midwives based in other hospitals. The Minehead Hospital, for example, is the base for our Exmoor and Minehead community team, and we do use rooms in other hospitals. It's very much appreciated by the midwifery team that we can use these spaces, and it offers opportunity to work with some of the other services in the area. Our longer term plans for improvement of certainly of our community services is to develop these hubs so that we can work even closely with our colleagues such as health visitors, public health nurses, local GPs, etc., so that we can really provide more holistic community-centred care for our women and their families.
Thank you very much. I'd like to go now to Councillor Woods.
Thank you. I was surprised to hear Councillor Wakefield try to move her monkey. I think that's an expression that's used when you move your problem onto somebody else, and you are actually moving the problem onto the service users. I don't know if you agree with that, but there was also a problem with language, and I'm not going to repeat what you said there, because I think it was inappropriate. Thank you. I did have a question about the Mary Stanley, which is Bridgewater based, I would imagine. It says only 5 beds available. Is that because there are no physically any other beds, or because of something else? Because I know from going back a long time when I was at the Mary Stanley, that's an awful long time, it was well used, not only from Bridgewater, but the outlying areas. Thank you. I don't know if you have an answer.
Sally, can you come back to that, please?
Yes, I can. Thank you, Chair. So the Mary Stanley unit at Bridgewater Hospital is a birthing centre that was offering births to women in the surrounding areas. As you rightly say, the Mary Stanley traditionally have been incredibly well used. We've seen quite a significant decline in the number of women choosing to birth at Mary Stanley over a number of years. And in the report, the number 5 is relating to the amount of births that happened in that previous year. So as you can imagine, 5 births in 1 year is a really low numbers compared to what we had seen previously. There is a declining wish from the community to have Mary Stanley as a birthing option. Since we have suspended births there, we've had only 1 family come forward to inquire and who wished to birth there, and they were more than happy with the alternative, which was our alongside birth centre at Musgrove, Bracken Birthing Centre. So we're doing a piece of work to understand what the ask of the community is and what we might need to do to develop services so that we can deliver that in the safest possible way for the community. But it's certainly a declining ask of the community.
Thank you, Sally, for that. I think you're absolutely right. I think that I know when I was at Musgrove all those years ago, you were in Musgrove, but now people aren't in Musgrove long. They fortunately had their birth and they're home within 24 hours, walking around getting the shopping. Life's different. Life's moved on. But you're in a good hospital that has normally a good record. I think what we need to do is have an action plan. We definitely need to be an action plan, and we need this monitored. So I would say that's vitally important that Andy, we have you back if we may, or your colleagues, very soon. I think we need to give you time, but I would say that I'll come back to you, Sarah, of course. I think what we do need to know is that we need to give you the opportunity. So if you want to come back, I say 3 months. Would you have an answer in 3 months? We need a briefing. It would be really good for us as a committee to know exactly what the CQC have said, how they feel about it. But one thing what we've got to do as a scrutiny is make sure that we don't want this ever to happen again. You don't want it to happen again. Nobody does. But what we've also got to do is, out of this, some positives will come. And that's the way forward for us to positively think that they've found areas of concern. Those concerns will be dealt with, and we give mums and parents confidence that there isn't an issue, and that's where we need to go forward. And sometimes we have to express how we feel in very different ways, but I think we need to make sure that we want you to have the confidence. We want you to give us the confidence as well as a scrutiny committee that we're doing the right job. Okay, so I'm going to now go to Sarah. I don't want there to be a massive debate about this, Sarah, if that's okay. Just
I just wanted to say, as my name was mentioned by Councillor Wood, that I was reporting, if you recall, what somebody had said to me on the doorstep. I wasn't necessarily saying I agreed with it. I said that the midwife spoke to me on the doorstep and said there are problems in the way the service runs for her, in that people turn up in labour, which is very difficult to deal with when you've got other people who you knew were coming in or who've already been booked in, and it puts the service under more pressure. So I was simply making that point, and I think that's a reasonable report from somebody, as I say, who works in the service, who is extremely upset about this report and feels that it doesn't adequately speak up for those who work in the service and how much dedication they have. So that's really what I wanted to say.
Thank you very much. And we all know that the CQC is a dedicated inspection. We can't change the report, we can't change what's said, but what we can do is change the outcome. So that's what we're going to do. So, Councillor Oakes.
Yeah, thank you, Chair.
24 Yeovil District Hospital Inspection Report.
So,
and
excuse me, Councillor Woods, can you take your sound off, please?
I don't know what turned it on.
It's a computer.
It was a computer.
Okay. The action plan exists. The action plan's being implemented. There's no real reason for delay about it coming back to this committee so that we can trawl through the action plan. But can I just make it a point that the way the CQC's request for an action plan will be to identify the issues that they've identified, and quite clearly there are concerns over governance. Lack of governance on a massive scale. And I would make 2 points. Firstly, when a report says there's a staffing problem, it's not overly helpful to be told that there's not, which is what this committee has heard this morning. Now, there is a staffing problem, whether it's a midwife issue is a different one, and that's something we can look at again in more detail when it comes back. But the thing that is missing, and it's going to be missing across the whole body that you're responsible for, is the lack of knowledge of service, should we say. There was a lack of knowledge of service of this. There were so many issues found, so much poor governance, and the action plan will not actually ask you to really, they'll ask you to deal with those issues. My advice would be that you need to find some organisation, maybe another trust, to come in and to do your mock inspections and to find this before CQC come, to improve those, to take out the safety issues. Anyone who actually reads the report will see time after time there are really positive things in there about what the midwives, etc., are doing. The service is not inadequate in those terms, but the wider service and its governance is, and it has to be accepted and it has to be dealt with at the right level. And maybe also have some concerns that there's an awful lot of people who are a long way removed from the sheep face who are involved in this. I look forward to the action plan, and I wish you all the best, because you're facing a very difficult situation.
I'm going to go to Sally, and Sally's the last speaker on this. I think we've really, then I will just round up if that's okay. So go to Sally, please.
Thank you, Chair. I just wanted to give you a little bit of information on how we're responding as well in response to the last speaker. We've got a really good working relationship with our colleagues in Bath, who have recently received outstanding CQC ratings. And the Director of Midwifery in Bath and her team have kindly agreed to come down and visit us and help to scrutinise the work that we're doing in response to our CQC inspection and outside of that as well. So we are looking wherever we can to some external eyes and ears to help steer us in the right direction. And we're also being very well supported by our ICB colleagues and our regional chief midwife as well along that process.
Thank you very much, Sally. And we have to be positive. The one thing I would say is the report was very meaty and very long. I would ask you that if we can have the next report to be summarised, but the vital issues, I'm not saying to track from the main thing, but the report was far too long. And I think sometimes when a report is too long, sometimes it's missed, areas are missed. But I understand why you did this one. But there's no need, just give the summarised view and we will appreciate that, and I'm sure you will as well. So, Andy, do you want to?
Yeah, thank you, Chair, and members of the committee for your time and for your questions today. We will be delighted to come back in 3 months' time. Oh boy, have we got an action plan, and we're very happy to share it with you straight away. And I would just echo the comments of my colleagues. Hugely grateful for the Maternity and the Neonatal Voices Partnership, who represent women in the county. They're at the centre of all that we're doing. And also to our colleagues at the Clinical Commissioning Group, who are rightly supportive and challenging and on our shoulder all the way with this, but very much alongside us. So we're very grateful for that, and we look forward to seeing you in 3 months' time.
Thank you very much for your colleagues. Thank you, Sally, and Andy for coming along today. I really do appreciate you being here. This is obviously a very difficult situation, and we appreciate that. But we're going to throw the gauntlet down to you that when you come back in 3 months, it's going to be good, and that's what we want, and we all want that very, very much. But thank you for your time today. I appreciate it. Thank you, Sally, and I'm so sorry, Claire. Thank you. Okay, we go now to item 8, which is the social care workforce. This is page 9954, and I hand over to Emily Fulbrook, please.
Yeah, I'm just going to introduce it briefly. I'm very pleased to see this full report coming before the Scrutiny Committee. It's got a lot in it. Excuse me. Another long report, but it's got a lot of meat in it, and it's very interesting to read. I hope you all found that. It's very important to our staff that they have a direction, that they are given direction. We have a very committed team already, I would say that, but this is also about the way the outside views us. So if somebody's thinking of going into adult social care in Somerset, if you've got a good strategy like this that they can look at, then they're more likely to come and work for us. So that's also an important point. Thank you. Let Emily take over.
Thank you. I know you've got the presentation in your pack. Is it helpful if I share it on my screen as well, or not?
Yes, if you can, that would be fine. For some people may not have it.
Thank you. Okay, I'll just share it on my screen for people. So just while that's coming up, so hopefully you should be able to all see that now as well. So this is a joint adult social care workforce strategy presentation. So I will start and I will go through the adult social care internal workforce across both across our directorates and within all service areas within adult social care. And then I'll pass over to Paul Coles to go through the workforce strategy in terms of from an external recruitment within our provider market. So I just wanted to highlight in terms of the brilliant work that has been done across adult social care surrounding our adult social care workforce strategy, and that's been relaunched. So we've relaunched the workforce strategy for 2024 to 2026. There's been significant work that has been completed on this, building up in terms of an evidence-based learning and feedback from our workforce to help create in terms of the new workforce strategy that is being looked at the moment across the organisation as a really good example in terms of how we would want further workforce strategies to be completed within the organisation, and is helping inform some of that practice as well. You may recognise some faces within our workforce strategy. You've got the workforce strategy with a part of the pack as well, and a very, very detailed, which I haven't gone into here as much, but you've got that in your pack in terms of the workforce strategy that has been launched. So as part of that workforce strategy, what we have done, so it sets out our ambitions for the future across our internal workforce over the next 2 years. And it's got 2 main central focuses. So it's surrounding recruiting and retaining and developing and training. And throughout our workforce strategy, the key performance areas, our achievements, any concerns are all monitored through our workforce board as well. In terms of within adult social care in Somerset, so we have three main functions within adult social care. So we've got our operational function, which is made up of our frontline social care teams. We've got our commissioning function, who help shape and care our care market. And then we've got our strategy, transformation and performance function, which supports all of our assurance and improvement activity. And as you'll remember, we have recently had our LGA Assurance Peer Challenge feedback, and there's quite a good quote there in terms of the feedback that they gave us surrounding the passionate and experienced and committed staff and senior leadership that we had within adult social care. We've done, to inform the strategy, we've done quite a lot of work with our workforce across all of those three service areas. And what our workforce has told us, these are the 7 sort of key things or in a priority that what they would see that matters most to them. And you'll see there that what matters most to them is surrounding their well-being and how we're supporting our workforce surrounding their well-being. We also then move down in terms of to training and recruitment. So minimising the need for any temporary locum workforce, and then moving down in terms of to things like induction for our workforce as well. So we've really taken on board those activities and what our workforce has said to us, and that has helped really inform our workforce strategy. You've got these in your pack, so I won't go into too much. I won't read all of those out. You've got them there, but these are some of the key things that our staff have told us. These are some of the really positive things in terms of there's a strong, compassionate leadership, that we care, that the continuing professional development offer in Somerset is fantastic, proud and passionate, ensuring that the best possible outcomes, ensuring the best possible outcomes for people. So there's some really positive things here. And some of the things that they've told us that actually we need to work on, and which is again included and features quite heavily within our workforce strategy as well. Now these are across, they're not just in terms of the operational, so our frontline teams, these are across our commissioning colleagues and also our transformation quality workforce as well. So one of the main areas that our staff told us about was about recruitment. And as we've heard in the previous presentation, within adult social care, we have challenges in terms of recruitment as well. So what we have done is we've looked at our international recruitment, particularly from a social work point of view. And I'm pleased to say that last year we recruited 12 social workers, were recruited internationally. We used a company alongside Children's Social Care to recruit 12 social workers who have come over to Somerset and are now developing their life with us here and have been fantastic. They've settled in brilliantly, and we're not only are they learning an awful lot from us, but we're learning a great deal from them as well. We have since started our recruitment process for a 3rd cohort, so we have interviewed for 10 further social workers to be as part of the international recruitment as well. We've got a dedicated HR engagement officer that is providing support to newly recruits, and we're also doing some work across the southwest with ADAS surrounding actually how can we support people to come over to the UK and particularly into the southwest region and settle well, because there's a huge cultural difference as well for individuals. As part of our recruitment, we also grow our own. So we grow our own social workers and occupational therapists. So we run a good apprenticeship scheme. And this is Sophia, who is she started within the Yeovil Hospital as an apprenticeship. She has now completed her apprenticeship and is now moving on to undertake her social work degree. We have the same here for Lindsay. So Lindsay is an OT degree apprenticeship, And Lindsay is one of 5 apprenticeships we've got 2 cohorts running at the moment. And Lindsay has worked in the South Somerset team and is now moving hopefully to progress towards being a qualified occupational therapist. We also run a return to practice. So Natalie here is a return to practice of an occupational therapist. We run that as well for social workers, where we've got some people that have taken time out from their professional career, and then we support them to regain in terms of their registration with either Social Work England or within ARCOS as well. And Natalie is an example of how we've been doing that last year and continuing. So in terms of our 2022-2024 workforce strategy, you will see there that we had 10 key themes. So recruitment, retention, pay and conditions, succession planning, new ways of working, young people, learning and development, leadership, partnership working, and the implementation and monitoring. So these are just some key sort of stats really in terms of what was achieved. This data was taken from March, so it was from April, so it was the previous year. So you can see there in terms of what we have achieved in terms of new starters, our recruitment to the 12 internationally recruited social workers, our turnover in terms of social workers leaving Somerset Council had reduced quite significantly. Our succession planning, particularly within our approved mental health professionals, so our AMP service, that age profile actually was quite high, and we've done some succession planning, introduced a trainee AMP role, which has supported that service. We've implemented phase 1 and phase 2 of the adult social care operational restructure, and we've provided 1,700 training places across our workforce as well. We've also implemented the 360-degree leadership feedback, which is across our senior managers, and we're looking at how we can implement that further down into our workforce as well. To also help inform our workforce strategy, we took what's called a SWOT analysis, so looking at our strengths, our weaknesses, opportunities and threats. So we really informed that, again, linking and learning in across our workforce, and that absolutely helped inform our workforce strategy. So just to pull out a few key areas in terms of for our workforce strategy. Like I said, you've got the workforce strategy within your pack as well. And again, we're looking at the 2 priorities. So we're moving away from the 10 and we're looking at the 2, and we're bringing that in together to sort of recruit and retain, and then develop and train. So you'll see there in terms of some of our key areas in which we're wanting to progress on in terms of recruitment and retain. So that's really looking at our international recruitment, trying to reduce our reliance on locum staff, ensuring our recruitment communication and engagement approach is beneficial, and it brings us good quality social workers, occupational therapists, adult social care practitioners, commissioners, etc. into adult social care. And then our develop and train. So this is surrounding our development of our workforce, making sure that our training offer is appropriate and is in line with the needs of the workforce, and then in particular in terms of the needs of the public as well. It's looking at our leadership qualities as well, and development programs, the support that we give to post-qualifying social workers, the newly qualified social workers, newly qualified occupational therapists as well, and also linking that in through to commissioning as well. So making sure that we've got the right training and the right development in place across our commissioning workforce. Just really wanted to focus on some data. So in terms of the workforce, the operational workforce, I think when I presented at Scrutiny a year ago, we were just about to go into phase 1 of the adult social care restructure. What you can see here is since we have undertaken phase 1 and phase 2 of the restructure, we've seen a significant improvement in the retention of our operational workforce. So we've, you can see there from the data back in July 23, we had quite significant vacancies. I'm not saying that we haven't got vacancies now, but it's significantly improved. Here again is surrounding our workforce, and we call it working days lost. So this is down to sickness. Now, Adult Social Care Operational Service used to have one of the highest working days lost consistently out of all of the council directorates. We are now broadly in line with the working days lost across the council. So we're no longer the top spot any longer, which I'm very pleased to say. So this has been consistent over the last few months now. It's just worth pointing out that the top one at the moment is surrounding strategy, adult social care strategy, transformation and performance, and that's due to a specific individual who has had some quite significant long-term sickness, so that has impacted on the data there. So in terms of our adult social care operational workforce, just wanted to really bring to your attention, because it may help in terms of the next item, or item 9. And so in May 2024, our operational workforce showed that we had 73% of permanent employed staff members, and we had a 27% vacancy rate. That in total, that's 140 vacant posts across our operational service. Out of those 140, we've got 27 people in the pipeline. So they've had their interview, they're going through their recruitment checks, and they're on their way into becoming a permanent member of staff. We've got 56 locums, so that's temporary staff members, and that is across our social workers, occupational therapists, our advanced practitioners, and our service managers as well. We wouldn't be able to run an operational service without that temporary workforce, so it's a necessity. But what we are wanting to do is to recruit into permanent workforce, so we're wanting to replace those locums. As part of the financial emergency and the establishment of the Establishment and Recruitment Board, all vacancy requests needed to go through the spend board. As we're all aware, we have various spend boards set up. What we did within the Adult Social Care Operational Service is that we completed a business case for approval, which we continue to monitor through our senior leadership meetings. We're working very closely with HR at the moment as well, working very closely with universities. Our principal social worker and our principal occupational therapist is heavily engaged in recruitment activity as well, in terms of being able to make sure that we're recruiting to those positions. At the moment, not all of those vacancies have got approval through the Establishment Recruitment Board, so we're working on a further overarching business case to gain and seek approval surrounding that. What I'm going to do now is I'm going to hand you over to Paul Coles, who will take you through in terms of the external workforce.
Thank you very much, Emily. I'm Paul Coles. I'm Service Director for Commissioning within Adult Social Care. I thought it would be useful today to look at the context of the wider, so we're going to go from a national context around social care, come down into the more local, and some of the opportunities and challenges we have out in our wider market. So starting off initially, people forget about social care. We are a big industry. We have 1,065,000 jobs, people employed within the sector in England. The adult social care market is larger than the NHS, construction, transport, food and drink, and other service industries, and is due to grow by 1/3 by 2035. Now, for a sector that is not understood, for a sector that is always challenged on staffing, I don't think we understand the context of what social care brings to our communities going forward, and it's really important that we understand that for the future. Some of the elements from a national perspective are, as we know, social care continues to be a challenging area to recruit and retain staff for a long time opportunities. So total post nationally is 1.7 million. Out of those posts, they are filled is 1.635 million, and therefore nationally there's vacancies of 152,000, which has caused a significant challenge in delivering care services across across England. This information has been taken from Skills for Care data. Thank you. Thank you, Emily. Sorry. So what about the local picture here in Somerset? So we have 19,500 in totality of posts. 18,000 of them are filled with 1,300 vacancies. And this will be across not just our independent sector, but also for people that provide direct payment recipients and the wider workforce in general. Overall, if you look at Somerset in its totality, we have 292 regulated services that are inspected by the Care Quality Commission. Next one, please. Thank you. From the local challenges, as you know, we've had difficulty recruiting, retaining staff into social care, and an element of that is around the fair pay that individuals receive. But one of the opportunities that we have had is around international recruitment, and as a local authority, we've embraced international recruitment, and our providers have stepped up and worked in the international recruitment. Just to put that into some context, one of our largest suppliers of care within Somerset, their uses of agency staff has significantly reduced, so they're no longer having to rely on agency staff. They have a core team to deliver the care that we need, and we know that people receive better care if they receive it from core staff members rather than the continued agency usage. So it gives continuity of care for our providers as well. Next one. So what have we done here in Somerset about raising the profile? Some of you might remember last year we did My Time to Care profile, which was, we did that in collaboration with the ICB. What we looked at is trying to get people back into the care industry, trying to look at posts that would be suitable, and we did a really thought-provoking campaign to enable people to come back into recruitment. This year we've also been and supported You Can Care Week, which helps shine a spotlight on the importance of social care roles and the positive impact they have on individuals and communities. Next one, Emily. There continues to be a strong appreciation and commitment to addressing both current and future workforce needs of the health and social care system. As we all get older, we're all going to need care and support going forward, and we want to ensure that people in Somerset have received the right care, with the individuals delivering that care that are trained to a standard that are able to manage the complexity of people coming through our system at the moment. One way that we're looking at doing this, and we're going to be supporting going through, is around, we have a system-wide ICB people board, and that is committed to supporting the wider health and social care workforce. And some of you will be aware of the innovation around the Somerset Training Academy, which will look to be based here in Bridgewater, in the old Bridgewater Hospital site. This is an innovation for us as a council, but also for the wider social care system as well. And what this will do is to create the care workforce that we need for the future. My job as a strategic commissioner isn't necessarily looking about today, it's looking about 10, 15, 20 years time to ensure that we have the right skills and professionalism to be able to manage the people of Somerset going forward. We're going to align to a service delivery, to a skills and business innovation and digital connection to stimulate and strong learning culture and network. By having the academy will give us the space to enable us to drive forward the joint priorities from ourselves as social care services, but also from the NHS and our wider social care providers. And what we want to be able to do with this is tackle health inequalities for our population and workforce through improved capacity in the care sector, and also through education and learning. I touched on it earlier, and Mel also touched on it within her introduction. International recruitment has really changed the way delivery of care here in Somerset. So at this moment in time, we don't have anybody waiting for home care, as where most probably about 18 months ago, we would have had about 182 people waiting at any one time for home care delivery. We don't have that currently. And part of that success is some of the work that we've done as commissioning, but also to support our provider market to embrace international recruitment. Some of the challenges within the international recruitment space is around, obviously, some recruitment organisations don't use scrupulous measures to bring people in. There are opportunities where people are brought into the country to do care duties. When they get here, there isn't actually a job for them to go to, so they end up in a really difficult, challenging position. This has been recognised by the previous central government, and one of the elements that are being taken forward is around Social Care International Recruitment Fund, and that's very much to support individuals that come into Somerset, come into the wider in country, to be able to be supported into employment, to be able to, when they're here, get the material needs and support that they require going forward. Some of the opportunities we have in this space is around, or some of the challenges we have in this space is around accommodation. As you know, Somerset doesn't have a huge amount of accommodation, so that's one area that we're looking at the moment, is how do we provide accommodation for workers. We're also looking at how we ensure that people are given the right support when they get here. It's the basic things. It's about navigating a different country. It's about ensuring that people are linked into their local cultural groups to ensure that people don't feel isolated and left out. International recruitment is something that we are really going to continue to work towards here in Somerset, because of the challenges we have of delivering care in a very local, very rural county. And one of the other elements that we are also looking at is, from a commissioning perspective, some of the challenges that other local authorities have faced is around when you issue new contracts and you have to duty staff over. One local authority, the incoming provider didn't have an international license, which then meant people weren't able to transfer over. So international recruitment, although we really embraced it, it does have to come with some warnings as well, to ensure that all our organisations are able to support people in the most appropriate way. But I'm happy to take any questions, or Emily, obviously, on the element. Thank you.
Thank you very much for that. That was very comprehensive. It's a big report, big presentation, I should say. I've got a question. I'll start it off if that's okay. Unless Emma, did you want to say? Sorry, I do apologise. And you did nothing. No, sorry. I just wanted two questions really. I think the care sector is a underrated establishment. I think, and you know what? You focus your brain when you get older. You suddenly realise, I'm going to need this. Hopefully I won't, but you never know. And I think that does focus, and I think it's an incredible area. And it's good that we know. A little bit confused with sometimes when you had people, like you said, there were 70 and then 40 left in a year. I'd like to know why they left. Wouldn't mind knowing that. I also would like to know, and I mean this nicely, do carers get scrutinised as well? Because you do hear from some people, that one is better than the other one, that one's more thorough, all this kind of thing. Do they constantly get scrutinised? And the other thing I'd like to ask is, full-time carers, because we are living longer, full-time carers, those that do 24/7 care in homes, are we managing to, because it seems to be a lot of people having to go to the private sector to get that 24/7 care. Do we have that availability? Because we're advocating people come home. We're advocating all the time saying people shouldn't go into nursing homes unless if they've got a house that can be adapted. And yet people are saying to me they can't find 24/7 care. Sorry, there's a couple of questions there.
I won't answer all of them. I'll do the first one and then I'll hand over to Paul. We might do a bit of a mixture on the final one. In relation to the stats that I've shown in terms of 70 leaving and then 40 coming in, so that could be a mixture of people. So that would be either a social worker, adult social care practitioner, occupational therapist, service manager. anyone in terms of across our workforce. So they could be leaving due to retirements. It could be that actually they're leaving the local authority because they're moving away. It could be that they're moving the local authority because they're going to North Somerset or they're going to Devon or another area. It could be for a variety of reasons. What we do is we always do a exit interview so that we can start to learn and track through actually what could we have done differently. Some of it we can't do anything. If somebody's retiring, we can't change that aspect. But we do learn from that. We do that in relation with our HR colleagues as well. And we monitor some of that aspect as well, part of our workforce board that helps shape and improve and definitely links into the retain element. So recruit and retain, develop and train, it all links into there. So those exit interviews are really, really important. And then the 40 new are obviously our new staff members permanently recruited. So in terms of balancing that out, but yeah, that's the reason why people leave and how we monitor. In terms of the carers, did that answer that one for you?
Yeah, that's fine. Thank you.
In terms of the carers, I'll hand over to Paul initially.
Thank you, Emily. With reference to carers delivering care out into the community, all of the providers that we work with have to be regulated with by CQC. So there's a whole regulation around the individual and also around the care delivery. As part of our level of scrutiny as a local authority, we also have a PAMS platform, which is a way of us monitoring our providers as well, which we expect them to complete on a regular basis. As part of our contractual arrangement with our provider market, we also expect our providers to have a robust process around supervision, and we go in and monitor how regularly people are supervised. But obviously, it's down to individual delivery as well. So, personalities, that's some of the challenges with care deliveries. Not everybody gets on with people. So, it's around matching people up to the best possible ability. We have a real close oversight of any concerns that come through to us. And as part of our quality assurance process, we follow up those concerns with the provider market and expect them to complete a report. And we will work if there's any quality concerns to improve that organisation, or if they are not in the position to improve, we will work with them to exit the market as well. On your second point, in relation to 24-hour care, there is capacity within the market at the moment around 24-hour care. I think we were able to source one last week within 2 days. I suppose it's around ensuring that people have the information around the organisations that they need to go to. So we don't have any problems at the moment with our home care delivery at all, which has never really been the case. However long I've worked in social care, which is 20 plus years.
I have to say, I've got to Mel, I have to say that's really good news, because that's not the feedback that I've been getting, and maybe other councillors don't get as well. So that's really good to hear. But I'm going to pass over to the expert now. Not that you're not the expert, so sorry. Another expert, sorry.
I think what we have to recognise is that somebody may think they need 24-hour care, but actually we will assess them and say, actually, you don't need that. And that's probably what you're hearing. Or, because, it's quite rare for us to be saying putting a whole package into somebody's house, which is a 24-hour. We do put in some living care options, but that's probably the exception, not the rule. Because if somebody is needing that 24-hour care, the reality is that person's probably would be better off in a residential or nursing home. It would be probably for us, if we're frank and honest, it's a cheaper option for us as well. But also, if somebody just sat in their house all the time on their own and needs such a lot of support, what is the quality of life of that individual if they haven't got anybody else to come and support them? So there is that question at times. So it'll be based on somebody's assessed needs. Now, somebody may choose, actually, I really want to live in my own home. So what we'll say to them, well, this is your assessed needs, and this is the amount of money we would fund. If you want to have somebody to come and you want to stay in your own home, you're going to have to fund the rest yourself. But there are living care options out there. So they're out there. Rarely will we probably be doing that. I don't know how many we've got at the moment, but I'm sure my data geeks will be able to tell us that, no problem.
I can't give you the data off the top of my head, but I could probably do some work in the background, see if I could find it by the end of the meeting. But Mel's absolutely right. And a lot of the time it's based on need. And as Mel said, very often we will get people coming saying, I need to have 24/7 care at home. When we do our Care Act assessment, when we talk people through what their aspirations are, and going through that sort of strength-based approach, sometimes that's not always the case. We've got some examples of when we're doing that, not just within our older population, but also from a transition point of view as well, with young people with a learning disability, and maybe sometimes parents' belief of how somebody needs to be supported. So we've got some really good examples of actually how we've taken people through on that journey as well. It's not so that we don't offer living care. We do offer living care, but it has got to be, when the risks can't be managed in other ways, there's all sorts of other factors that need to be taken into consideration as well. And then it comes down to what actually can be looked, is that the only way somebody's needs can be met, or is that one option of how somebody's needs can be met? So that's when we end up into sometimes some quite complicated conversations with individuals and families.
Yeah, if I may, I'll come back to it. Sorry, I may just on this point, I find difficulty that people aren't offered home care first, but they're not. Not in reality, they're not. I can name you loads of people that have not been offered home care. They were offered a residential care, and then when they said, well, actually, I'd like to be home. Well, oh yes, that can happen. And what I did was I've done a little bit of delving. And I found that it is finance, I get that, and it's all those other factors. But what I would like to see is first, because Newton York suggests that that's where you go home. I would like to see that is offered first. Can you go home? First off, can you go home with some 4 times a day care, or can you not? If you can't, then then the residential home afterwards. And what I found, and I have experience, and I can tell you about it later, that's wasn't offered.
I would very much welcome to have that information, Jill, because that should not be happening. The only time that I can think that may well happen is when somebody is being discharged from hospital and the recommendation is to go through the intermediate care process. But again, if the individual is saying, even in that respect, that I want to go home, we should be making every single effort to support that individual to go home. Now, we run peer forums and enhanced peer forums. I personally chair our enhanced peer forums. I am absolutely supporting people to live at home, where appropriate, where possible. And we're looking at placements that very often in the last resort. I've offered it out to the committee members before. You are more than welcome to come and sit on our peer forum, come and listen to the conversations that we're having. Councillor Wakefield has been, we've had other executive directors been to come in and visit. Please make contact with me, because they operate 5 days a week. They're still going, so you're more than welcome to come and listen to some of those conversations. But I would absolutely want to pick up with you in terms of those examples. Thank you.
That's excellent. Thank you so much. But it's really good to hear you say this, because that's a bit comforting. So thank you very much. Right, I'd like to now go to Councillor Bailey, please, who's online.
Chair, can you hear me okay? Hello? Can you hear me okay, Chair? No?
Yeah, we can hear me.
I can hear you, but I'm not getting any response that you can hear me.
We can hear you. Yes.
Oh, okay, fine. Shall I carry on?
Please.
Right. Well, I'll try and carry on. The sound's not very good from your end. Firstly, I just wanted to say thank you for the presentation, which include the slides and link with that. I think it's a much better way of presenting, so that we can all link the visual with the sound as well. And I felt very informed by that. That's the first thing. Secondly, very positive, it seems, in terms of what the information you were giving to us. So thank you for that. I just have one question, really, which was about the recruitment areas, recruitment and development. It's and you compared with the rest of the Somerset Council in terms of the working days lost. Have you got a plan to move on to look at peer groups? around the countryside who would then extend the targets that you've got for yourself.
I might just need a little bit more information, Councillor Bailey. In terms of linking in with peer groups for the targets, because we link in with our. Sorry, I'll let you come back.
Yeah, I'm getting all sorts of feedback here, so hopefully you're not suffering the same. It was in terms of, I'll just pick up the working days lost, for example, and how you'd move to within the sort of council average mean. Can't remember the figure you're using. And I just wondered if you had plans to then move on to say, well, around the countryside, we could go even better than that. Because I'm aware that's an opportunity to say, well, if we're recruiting, can we improve our recruitment above the rest of our, I'm going to call them competition, if you like. It's the next stage on, really. Does that clarify? I'm sorry, I can't hear you guys at all now.
I'm so sorry. So sorry. Hold on a second.
Somebody keeps muting my microphone, which is the one that's picking up the room. I didn't realise that I was causing feedback to Andrew Pritchard. So can you stop muting me, please?
It's been trying for 2 years.
Can you hear me now?
Yes, I can, yes.
Brilliant. Okay. So what we're not doing is we're not stopping as where we are at the moment. So we are constantly looking at how we can continue to develop. We've made significant strides in terms of the working days lost across our sickness levels. What we're trying to do is learn from that so we can continue to improve. And that's why we use our workforce board on a monthly basis, is to really sort of drill down, hold that mirror up in front of us and always constantly strive to improve. We're learning from other areas as well. So we are learning from across the Southwest what other areas are doing in terms of their recruitment and retention as well. And we're also learning from across internally, so across the organisation directorate, and likewise other directorates are also learning from adult social care. Hopefully that answers your question.
Yes, it does. Thank you. And apologies for the sound quality.
Councillor, thank you. Can I go to Councillor Ashley Richards, please? Councillor Richards?
Councillor Richards put their question in the chat, but I will read out again because I think there is some issues with sound. The question is, the end users will be at risk without international imported staff who don't have a good language skills. This also affects the staff fitting in and being retained. How are we addressing this?
It comes back down to the whole recruitment process in relation to when providers bring international recruits over. One of the elements is around them being able to communicate, but it does cause issues for older people. I know it does, definitely, but it's around our providers ensuring that the people that they're recruiting in have a level of English so that they're able to communicate in an effective way with people with dementia, for example, or living in the
Can I just come in from a social, that's absolutely from the care market, but I'd just like to address that from a social work point of view. And for the social workers that we've had in, we have, as part of the LGA that we had coming in, they looked at some of the quality of our assessments as part of that sort of pre-work. And we put forward some of the internationally recruited social workers as part of that. They had 5-star ratings for the work that they had done, for the quality of their assessments, for the way in which they completed a person-centred, strength-based approach, and also from the feedback that they had with individuals who they supported. So we, as part of the work that we do with the recruitment agency, there's some of those key things that we need to make sure of is that people have got a good IT skill set, that they've got good basic understanding of English. However, these are qualified social workers that are coming in and supporting us, and we are learning a tremendous amount of stuff from our internationally recruited social workers here within Somerset Council. But I just wanted to highlight the quality of the work that we are getting from those social workers is outstanding.
That's good to hear. Thank you very much. Can we now go to Councillor Hilary Bruce?
Thank you, Chair. I've got 3 points. Do you mind if I ask them each one separately rather than all together? First of all, I just want to say thank you for bringing the report. It's been long awaited for, and I'm really, really pleased to see it. So much information in there. There are some encouraging trends. I think not huge changes yet, but going in the right direction. I think that's really good to see. My first point really is about some of the things your staff told you or told us. One of the seems awful to pick up on the negative things. There are some good things that seem to be there's good kind of peer-to-peer working. They seem to like working with each other, and that seems to be a really good atmosphere on that side of it. On the more negative side, I would say that there seems to be a need for more frontline up change. That's one of the things I picked up on. What I'm worried about some of the comments about poor visibility of managers, inconsistent supervision, and that strong and skilled leaders are needed, but that's not always the case. So my question really is, this indicates that some of the leaders are probably not as close to their teams as they should be, and potentially they're not listening enough to their team. My question is really, do you think that's true? And if it is, what's being done specifically to address that? That may be, in one of your slides, talks about post-qualifying standards practice supervisors program. I'm reading that out because it's a long and complicated phrase that doesn't mean too much to me. So maybe that contains some of the answers to my question, but if you could clarify, please. Thank you.
Yeah, thank you. And I think when we had feedback from our workforce, we probably all focused on the negative and not necessarily the positive. And that's generally what we do. So this was taken at a point in time in order to refresh our strategy. So some of this has been developed on. What we've taken action, though, Councillor Bruce, so I want just to reassure you, we've now got a staff engagement focus group that we've got as part of our workforce, so that any key issues can be, we're not waiting for a meeting where we're asking for people, we're doing some dedicated response times. In terms of the development in terms of our workforce, we're developing our team charters, so across all of our workforce. So that sets out some of the expectations, how we're all going to behave with each other, and that's at all levels as well. In terms of the visibility of our leadership team, now that our leadership team could be us, but it also could be some of our service managers, team managers as well. We had, at that time that we were reporting, and still now to a certain extent, we had vacancies. So we had some team areas that didn't have, they weren't fully recruited to in terms of their service managers, which was causing staff to feel sometimes quite isolated, given the size of some of our teams as well. And in terms of that strategic manager support, we did have some sickness. That's since improved now as well. So we're monitoring that. There's a commitment from the operational senior leadership team that we're much more visible, and we're trying to move our sort of meetings around the county so that we're much more closer to individuals. We're not just doing that in the 4 main areas, we're also looking at how we support that from a mental health point of view, and also within our hospital setting. We've had Councillor Wakefield that has been going out and being very visible across our teams as well, and our teams really like that. They're very encouraging when people come in, and they're always very proud of wanting to show people what they're doing. So we're really focusing in terms of that as well. In terms of the post-qualifying standards, it's quite a social worky speech, I suppose, and it's much more about those individuals that have it's that post-qualifying. So once you've qualified in terms of sort of a senior leadership, it's then what happens and the standards then that come into it. we've got there's a whole piece of work that has been completed on that. It's not nothing that we've done. It's a national direction, and we've got it's about the post qualifying supervision award. So I can give further details surrounding that, but that's very much led and monitored by our principal social worker as well. We just one other thing, we are trying to do many more drop-ins as well. So either in-person drop-ins or virtual drop-ins. Somerset is a large local authority, it's a large area, so to try and get for myself to be able to get out to all of my teams is very difficult. But that's why we're trying and doing things on a road basis, because the visibility. I've been upstairs with the team all morning this morning, and it's really important that we make sure that we get that visibility out.
Thank you. Yeah, I think I've got the impression that rather than kind of senior leadership visibility, it seemed to be more of the frontline team leaders and perhaps a bit more kind of leadership skills training maybe needed in that area to improve that as well. Thank you. May I ask my second point, Chair? Okay, thank you. So one of the good pieces that I saw in there that seems to be a reduction in turnover of social workers. So I think that's to be celebrated. That's great. Some of the data about the leavers and the starters. So as Chair mentioned just earlier, the 41 leavers. The report says the main reasons, one of the main reasons is resigned, retired. That you say that the exit interviews happened. So the data in terms of splitting that down, in terms of not just resigned, why did they resign? I think that needs to be included in the strategy of the report so that we can monitor what those reasons are and if they're changing and improving. That data's there, so please, if we can include it. And in terms of the starters, of 70 starters, so the table that's in this, I think it's in the strategy, page 151 of our pack. It says there are 70 starters, but in terms of splitting down what roles those starters are, they're not all visible in the table on the strategy. So that might need to be adjusted so that it's all visible. I think it's about 25 or something positions there. The rest of them, 70, I don't know who they are. But there's only one apprentice from what I can see of the 70 starters. I know that international recruitment is a good thing, and it, like I say, it brings good quality skills to the council. But I think we need to be focusing a little bit more on getting more apprenticeships in. So where are we expecting most of our new starters to come from in the future? Is it going to be the bulk through international recruitment? Are we going to have more apprentices coming through, returners? Where are we expecting them to come from, our new starters? And what can we do to improve the number of apprentices that come forward? Because I think we should be looking at giving more opportunities and attracting more of our local young people to these roles as well. Thank you.
Yeah, just so I think that's maybe something we need to take away, because we've got more apprenticeships in than that. So I think it's the line in which we're using from an organisation point of view. Some of our apprenticeships that come from a moving into social work or within occupational therapists will go into adult social care practitioner roles or OTA roles, which is an occupational therapy assistant role. So I think we probably need to, thank you for pointing that out, we need to get that bit better so that we can truly reflect that. Grow your own is absolutely important to us. So, and I've worked my way up through this organisation, through Somerset. So I'm a prime example of how and what could be done if we support people in the right way. However, we also need to have that skill set as well to support those grow your owns, because you need to make sure that you give people the right foundations that are coming in to a really challenging roles such as social work, occupational therapists, and I'll include in terms of from a commissioning point of view as well. So we need to have that mixture because we need to have the right skill sets. I couldn't have a one team just purely made up of newly qualified social workers or purely made up of newly qualified occupational therapists, because I wouldn't be able to give them the foundations that they need to have. So we do need to have that mixture and that level of experience. However, if I'm going to sit here and wait for all really experienced social workers, I may be waiting for a little while. So we do need to get that balance right, which again comes back to the points around making sure that our leadership is visible, skilled and able to support individuals. We still have a number of locum workforce, particularly within some of our leadership roles, so like our advanced practitioners, the sort of next level up from a social worker, who do a lot of our supervision. Now, sometimes those individuals they don't normally live in Somerset, so they will travel. So that we offer quite a bit of hybrid working. That does have an impact for our workforce. If you haven't got people in the team present there, sat at the desk next to people, and that's something that we're working on in terms of from that hybrid point of view. International recruitment plays a fundamental part of the sustainability, particularly for the operational workforce. And we've got great examples of how that's been done really well across both children and adults. And we're looking at how we can do that from an occupational therapy point of view as well. But I think it's also about shouting about what we're doing in Somerset. We're doing some brilliant things in Somerset, particularly surrounding adult social care. And I think it's also about how we make sure that we're getting that out. We're using our social media to support that as well. So there's lots of work that we're doing at the moment around that. But yes, apprenticeships, grow your own. We've got the commitments in terms of to the cohort for both social work and for occupational therapy. And we've also got that level of commitment in terms of the 10 now recruited, international recruited social workers. We're not rushing out for a cohort 4 at the moment though, because we just need things to settle down and make sure people have got the right foundations once they've come in, and we'll start to look and consider that over the coming months, which will be monitored by the Workforce Board.
I'll just come back to in terms of the target, in terms of where our new starters are going to come from. Is that the kind of information that we could include in the strategy, looking at nationally where people are currently recruiting from and what we are working towards?
So we look at it. I don't think we could have a target though, and I think there would be some. Not saying that we're going to only have a certain number of newly qualified positions, because that's not what we do. But what we do is we're quite careful in planning where a newly qualified social worker or a newly qualified OT, what team they will go into, because it's having the right support. And when you're a newly qualified social worker or a newly qualified occupational therapist, you do what's on, well, particularly from a social work point of view, you do an assessed and supported year in practice. And as part of that, you have increased supervision, you have a limited caseload, you have a various peer support as well. You need to build up a portfolio over the year. If you're a qualified social worker, that's fine. But now you've got that protected year in practice where you can really fine tune and really grow and develop into that first year of practice. So that's why we can't have too many newly qualified social workers in one team. And that's why we need to be able to spread that out. We have, in terms of our AMPs, so our approved mental health professionals, we have started a trainee AMP process. We've got 3 trainee AMPs at the moment. And this is a new approach. We've not done this before. And so we're really closely monitoring that with the university as well. Other areas have done that, but Somerset hasn't. So we're really monitoring that, and that all 3 are due to qualify, I want to say in the next sort of 4 weeks, which will be brilliant. And that has really helped in terms of that succession planning as well. So it's, we're monitoring across the board, but more than happy to come back and make sure that we've got some of that information as well, and where those recruits are coming from and how do they hear about Somerset as well. So we learn from it.
That's great. Thank you very much, Emily. Chair, the last point I've got to make is a really quick one. Just a comment on the strategy. It mentions the Adult Social Care Workforce Board. Could you include in the strategy who the members of that board is, please? Thank you.
And we've got our last speaker, I think, is Councillor Lawrence, but we are running badly over time. I have to say, I do apologise. Done a bad job today, but it's been very interesting. So I want you to make it quickly, please.
Do you have time to get out to talk to people in the sixth form before they go to university about the options of working in this situation, and to get them thinking about what they can contribute in the long term? Because I think perhaps from my experience with my own grandchildren, they don't quite understand what is available and how interesting this work is.
Oh, yeah. we do, is the short answer, but we do that across both from a social work point of view, occupational therapy point of view, but also from a provider point of view. And encourage and start talking about care as well. And as Paul has said, you know, the care market, the care industry is one of the largest. But is it the most recognised? Is it the most valued? And is it paid appropriately as well? And there's some of the sort of the much more national things that we need to be pushing.
Okay, thank you, Emily. I think you weren't your salt today. You've done a good job. Good presentation as well. I must say, always make it interesting. I'm going to allow people to have 5 minutes comfort break because we've been on hours, 2 hours, but we are up against it with time, and I apologise. Okay, thank you. Item 9 is overdue assessments and reviews. This is pages 155 to 172, and I'd like to invite Emily Fulbrook to present, please.
Thank you very much. I'm conscious of time, and you've all had the slides, but what I will do is sort of whip through this if that's okay, and hopefully you would have had an opportunity to read through this. Now I know this is an area that will concern many of us, concerns myself, concerns Mel for sure, and will also concern your constituents as well. So hopefully what this report will show is that we are making improvements within the operational teams, and that we are on the start in terms of being able to make sure that we are completing timely assessments and reviews for individuals across Somerset. There's a lot of information in here, so probably in the first few slides I won't go into too much detail, but what I would say is that we are not unique in Somerset here. This is quite common across the many local authorities in terms of waiting lists. That's not saying that that's acceptable at all, so please don't think that I'm saying that, but this is not a unique Somerset issue. There are, as you know, we've got high demand coming into adult social care, which has been predominantly over the last few years, coupled with workforce challenges, capacity as well, has created backlog. The demand management is an absolute priority for all directors across all local authorities, and we continue to work in partnership with the South West as well, looking at how other areas are managing their demand, how practice is being managed as well, so that we can make sure that we improve our approaches and outcomes for individuals. As you're aware, we've got CQC assurance that will be coming through, and so therefore there is an increasing intention and interest in the data surrounding assessments and reviews. I just wanted to, and I put a link in here, and I would encourage people to go and have a look on the Sky link that is there. Maybe not right now, but at a later date, go and have a look at it. And that really shows why is an assessment under the Care Act so important. And it also stresses the point that actually not everybody can just go and do this type of assessment as well. You need to have a skilled workforce that can undertake this assessment, have those good strength-based conversations with individuals, really looking and helping people navigate themselves through actually what is it that people want to achieve, what is important for people. And then in turn with that, what we end up doing is looking at support plans to identify what is the right level of support for people to make sure that those outcomes can be achieved. But I would encourage you to have a look on that. It's a really good resource. And if there are any questions surrounding it, then please come back to me. So within Somerset, to provide yourself and others with reassurance, so significant work has been done to address the waiting times for assessments and reviews, and ensuring that our practice is robust and consistent across our frontline operational teams. We've really focused on improving our data and our visibility in terms of our data, and supporting in terms of our operational teams to improve in their productivity. So in January, we initiated a weekly operational oversight meeting that I chaired. So I initiated that and I led that in those meetings. We developed a consistent set of indicators to minimise and monitor waiting lists and waiting times. And we provided updated guidance to our workforce using the LGA guidance surrounding monitoring and managing waiting lists. Just some key things I wanted to point out before we move on to much of the data, but since that time, teams are now completing 20 to 25% more work. So that's meaning that we can assess and work with people more quickly and prevent crises. So our productivity has improved. So young people transitioning through to adult social care are now averaging being assessed before their 18th birthday. Now, we haven't hit that target since 2021. So this, again, is a significant improvement, and we're on a trajectory to make sure that we are doing those assessments by the time somebody is 17. Since forming our learning disability team, our peer forums have increased and a focus on review and the quality of outcomes for individuals, and that has actually changed the average cost of some of our learning disability packages as support as well. And when we're talking about productivity, you could argue that actually more productivity, you're going to spend more, you're going to place more people into care, etc. We are monitoring that as well. So monitoring the quality of those decision makings across our operational teams. And what we're seeing is that the quality of that decision making is also improving. So proportionately, fewer people are being assessed as requiring long-term bedded support and compared to the baseline period. I will note, Jill, what you had said earlier, so we will pick up on that. And what we're seeing, even with that increased productivity over the 6 weeks period that we've been monitoring, at least 9 more people have stayed at home instead of going into residential care. So not only are we doing more in terms of our productivity has improved, our decision making is also improving as well. So the operational oversight meetings, just to give you that, they really focus on data quality, expectations and monitoring. We also applied the LGA managing and monitoring waiting list guidance. So that's things like, have you risk assessed your waiting list? So we have now risk assessed every single Care Act individual waiting for a Care Act assessment. And also in terms of review, and it also asks you in terms of how are you gaining assurance that your staff feel confident in supporting people to undertake that strength-based approach. Now, again, that is fed back into some of the decision making as well and the work that we're doing with our workforce. Managing demand for assessment and review. So how are we linking in with our community? How are we linking in with Connect Somerset, our talking cafes, our silks that Sarah mentioned earlier? And then how are you engaging with people on the waiting list? Now, this is something that is really important. So how do people know where they are in the line, if you like? And so how are we communicating back and ensure that if people are waiting, that they're waiting well with maybe support from the community or linked in with other agencies as well. These are our priority timeframes. So priority 1, priority 2, priority 3, and this is what our managers and advanced practitioners are monitoring and continue to monitor as part of the oversight meetings. So they've continued. I'm no longer chairing them. My head of service strategic manager for NAPIS is chairing those now, but the reporting of that comes up through to me on a fortnightly basis. So I would love to, so what we're doing is the priorities are a guidance, so they don't replace necessarily managers' decisions. So what we would also do is that there may be times when we have to adjust or flex some of that. Now that may be because we're responding to an emergency, we've got a care home closure or we've got a hand back of packages. There may be other things that are sort of critical stuff that we might need to adjust some of that with as well. We are making sure that our referrals are processed in a timely manner, so we're utilising our Eclipse record and our data dashboard as well. We are developing further our communication with individuals and looking at providing them with some expected timeframes. And this will more than likely be in a form of a letter. We're trialling it at the moment with certain teams to see how people respond to that and how people can contact us if the situation changes as well. Now, that will help us when we are working with Somerset Direct as well in terms of managing the demand coming through to them. So we've got the data dashboards that I've just said that have been created and that are used as part of that operational oversight meeting. And as part of the directors, we receive that data on a fortnightly basis, and that's discussed in my weekly senior leadership team meeting. So I would love to sit here and say that we're consistently meeting all of those timeframes. We're not in all areas. In some areas we are. In some areas we're absolutely meeting those timeframes, but not in all areas. So that's what we're working towards. Now, some of the reasons why we're not meeting those timeframes are to do with recruitment and workforce vacancies. We've just had the workforce, so we know that we've got 140 vacancies across the operational workforce at the moment as well. It's maintaining sufficient staffing capacity, making sure we've got the right skill mix across the service to meet the current demand and anticipated demand. And then it's that retention as well, and making sure that the staff have got the necessary skills to undertake those Strength-Based Care Act assessments, really important assessments, but also including some of those other assessments such as mental capacity assessments and best interest assessments as well. Now, I'm sure you would have all seen the data that has been in the pack. So you can see there in terms of the numbers of overdue Care Act assessments that have not got an allocated worker, so 436, and also in terms of our pending reviews. I've tried to break that down into separating out from our neighbourhood teams, so our community-based teams, our learning disabilities teams, and our mental health teams. Annoyingly, there is a little bit of the other in there. That will be, some of those will be within our thinks as well. So again, that's the data validation that needs picking up. You can see here in terms of the levels of completed Care Act assessment and completed reviews, you can see that dip, but you can also see that gradual growth as well. And that has absolutely been since January, since we implemented the oversight and monitoring board as well. You can see here in terms of the average timeframes to complete assessments. So if I just talk you through the larger slide, so the green line is those assessments that are within a 30-day time frame, which is our target. And then the blue line is those that are over the 30 days. So what we're doing, we're responding to new individuals coming through and also addressing the backlog. So we're not just focusing on one area, we're addressing the two. In terms of the working days to allocate a Care Act assessment, that is going up, and we expect that to go up and then come down. The reason why it's going up is because we're also addressing the backlog. So therefore, people have been waiting longer for that. Allocating timeframes will go up, but we expect that to dip back down as we really make a dent into the backlog. You can see there that the working days from allocation to Care Act completion has significantly come down as well. So again, that's the focus that we've been doing in terms of productivity and practice as well. This is our assessment trajectory. Now, it's a trajectory which we will monitor and track. So you've got there in terms of where we are at the moment and then how we want to come down in terms of reducing the backlog. Now, it's not just a question of completing those 436 assessments and thinking that's it, it's done, because we have around about 300 assessments becoming due every single month. So not only have we got the 300 plus that are becoming due every single month, but we're also reducing down in terms of the backlog. So that's where we expect to, if this is a trajectory based on if we just stay as we are, if we just stay where we are, so no more recruitment, anything along those lines, this is the expectation. I'm expecting that we will continue to recruit, and I'm also expecting that we will look by recruiting, we will increase our productivity. However, what I can't guarantee is that we don't have a surge in demand. So we don't have a 500 people wanting an assessment, or we have a home closure, or we have something that impacts in terms of our working ability. So this is what we are monitoring, and we monitor that through in terms of our oversight board. In terms of our outcomes, so what this shows is in terms of those people that have been waiting for an assessment, do they end up with a formal care and support package? Do they end up with something from the local authority at the end of it? Now, all the blue is yes, they do. And the green is that no, actually, they've ended up with some information and advice. Now, what we want is that green to be as small as possible, because we don't want to be people waiting for an assessment, to have an assessment, and then for us to give them information and advice. That should have happened much earlier on, much further on down the line. Now, there will be some people that will have an assessment, but won't have something from the local authority. Now, that could be people that self-fund their own care. It could be where we've undertaken an assessment to support a health decision, such as continuing healthcare, for example. It could be for various other reasons. So that's why we monitor it. So we don't expect zero, but we do. We wouldn't want it to grow any more than what that's grown at the moment. Now, I know something that has been raised, and we're starting to pull some of this data together, is looking at people who have died whilst waiting for a Care Act assessment. Now, we're monitoring this, and what you can see there is in terms of the months. The blue line is the average age of death as well. So we're monitoring that, because what I'd really like to understand is the location of where some of those individuals were. So was somebody in hospital? Was somebody at home? What was the activity that we were doing? How were we making sure that that individual was waiting well for that assessment as well? Part of the work that we also do, so not just coming to Scrutiny here, but we also go to our Safeguarding Adults board as well. And they're very interested to know is how many people are waiting for a Care Act assessment that then maybe tip into safeguarding. So we also provide a quarterly report to our Safeguarding Adults board as well, and we monitor those individuals that maybe have tipped then into safeguarding, and what are we doing about that, and actually how then are we reprioritising individuals. We also monitor our occupational therapy performance as well, and you'll be able to see that they've done significant improvement in terms of our occupational therapy, where they had quite significant numbers, and with the introduction of some of our occupational therapy assistants has really supported in terms of reducing down in terms of the backlog. We monitor this on a frequent basis. What I would say, though, is that due to, and I might need Paul to help me out here, the HRA, the equipment that has been issued, our OTs at the moment are also focusing on some of the equipment that has been, not necessarily by us, but what we do need to do is go out and review that. So that may well impact on some of these reviews. So again, that's what we're monitoring through the oversight group as well. And again, we've got the trajectory there based on if nothing changes, if we stay exactly the same. Another area that I know is of great importance, not just to everybody around the table and online, but also to myself and others, is surrounding our carers assessments. And it's an absolute commitment from us, and we've got that very clearly in our self-assessments. And it's part of our priorities from an operational group and also within commissioning, is that we increase our carers assessments. Again, you can see there since January, they have increased. Still not a high number, still not as high as I would necessarily like them, but they are absolutely increasing. So again, it's a positive moving graph. I feel like I've done a massively whistle-stop tour there. So, but anyway.
Lee, can I just say thank you so much. I think this report, again, was really helpful, especially some of the questions that have been asked my way. And you'll probably be able to ask, I'm only going to pick a snippet of an area where I know I've had concerns raised to me. but you have actually answered a lot of questions in with this, so I do appreciate. I think you're very bold doing a forecast. I think that's really very bold, and let's hope that you win, because I think you might. But what I want to ask is, and I'm going to start this off if everybody's happy, just to start this off, and then it's all about discharge planning. Part of our job here is to find efficiency savings as the scrutiny. That's what we're looking at as well. And in some respects, I think Somerset has been a bit caring, a bit over caring. And the areas where I found is people who are waiting to be assessed, sometimes they're sent to a care home. When they come from hospital, they're sent somewhere else. In that interim time they're sent while they're being assessed, they are not being charged. They are not being charged for being there. You know this. And some of them, I found out, are there a long, long time because they can't quite work out, do they go home, do they go here, do they go there? And what I'm saying is a vast amount of money is being lost. Somerset is paying for these people, really caring, and so there's no criticism about the care, but the cost involved. And they're waiting there and they're very happy. I'm not saying people aren't happy waiting till they're being assessed, but that might be an area where we in Somerset are being too kind. And I just would like to say that I know you're getting ready for me, I know Mel's getting ready, but hang on. So what I'm saying is, I would like to say is, have we compared our model to elsewhere? Is there something we could do better? I mean, we just seem like an overly caring Somerset, really. And maybe I'm being horrid. I just need to ask that question.
No, I think that's a very, very valid question, and that is very soon to be changed, Jill. So it's in track, and within the next within 3 weeks, that should be up and running. So we've have got measurements taken into place. So this is particularly when people are being discharged from hospital into intermediate care, that there will be a charge once the Care Act assessment has been completed, and there's very clear timeframes in terms of when that's going to be done. So yes. The other thing is when people potentially are in the community, so not in terms of from a hospital point of view, and we look at arranging respite, we do put a charge on as well. So there is an automatic charge of a client. We didn't used to, but we have done that now for the last sort of 2 years. We've been putting that charge in. So yeah.
I just wanted to explain before I bring the Mel, because Mel will sort this out completely, is the fact that many people have asked me the same question. Is this overlap of people sitting in a nursing home, residential home or lovely homes, but they are not paying a penny. And I'm not saying that I'm being really horrid by saying this, but in actual fact, it is coming down to this expense from Somerset. So that's why I'm saying the efficiency savings, I think, I'm glad to hear, but what I'm saying is they need to be assessed much quicker than what they are. But I'm over to Mel, who's going to now kick it into touch.
I'm not. We absolutely. So you'll often hear, and it's a rubbish term, somebody can have a reablement package up to 6 weeks. Well, I would say they have a reablement package until they need it, which is less than 6 weeks, but maybe a week, maybe 2 weeks. And after that period of time, which is at the local, so before that, health will pay. So if somebody has a assessed therapy need, health will fund that. But as soon as it comes, that need's gone, and the Care Act's done, then we have to fund it, so it turns to us. And that's what we do. Now, if somebody goes into a community hospital, slightly different. They don't pay for that. It shouldn't be any different, and we don't ever get charged for that. It shouldn't be any different. So what we're doing is the crack at the beginning is let's get those that are in our reablement beds that we know of that are proper reablement beds with therapy going in there, and then we'll tackle the reductions in our community hospitals. We'll do both at the same time. So it's a piece of work that we've in train. So you may hear some complaints coming out which says, oh, I'm now being charged, or actually I'm a self-funder and they're now going to charge me X amount of money a week, but I don't really want to leave that. Well, sorry, you may well get charged. After a period of time when your therapy's done, if you are a self-funder, we will be putting a charge onto you, which may help people move a bit quicker. That's how life goes. So it is about how do we support people in the right way, but charge when we can charge. You're absolutely great to pick that up. We'd already picked it up. It cost us last year, or cost the health and social care system, a couple of £1 million last year to do this, not do this as well as it needs to be. We need to get it nailed, and that will be done this year.
And it does sound a little bit mercenary what I'm trying to say in a way, but it's not fair. I know a number of people who have been in hospital or in residential home been there for 12 weeks, bless them, and then absolutely not complaining about anything, actually not paying anything. And I just think that just seems totally unfair to Somerset. And I think there's that gap. And what I'm thinking is, if that's happening to one person, then how many other people is that happening to? And how that cost is relating to Somerset, and it's something we should pick up. So thank you for. I know I sent messages too, so you knew I was on the pathway. But thank you very much. Right, members, do you have any other questions, please? Are you happy with it? The report is excellent, isn't it? Very good report, Emily. Very good report. Very explanatory, which is what we need. Thank you very much. Okay, thank you. So item now is extra care housing, and this is item 10, pages 1 to 73 to 180. And I'd like to invite Stephen Miles to present, please.
Thank you, Kate. I'll just sort my mic out and get the presentation.
And we need you to speak as loud as you can, please.
Okay, I'll turn my volume up. Okay, thank you very much. So this is an update on the recommission for extra care housing that Councillor Slocum asked for when we extended the contracts for the existing service for 12 months in order to allow this piece of work to take place. So I thought it'd be really useful to start with to talk about what extra care housing is, because it's a fairly unique service within adult social care. It sits between people living in their own home and more intensive types of service such as residential care. And in some ways, it's a partnership between the local authority as the commissioners, the care and support provider that provides the care into the extra care housing scheme, and the landlord of the scheme. Within each scheme, we have 14 in Somerset, and they are distributed around the county. Tenants pay rent to the social landlord and responsible for all their other bills. But the council commissions a care and support provider to be on site 24/7 to support individuals. And also the individuals living within an extra care housing scheme have, if they're assessed as needing one, would have an individual package of care. The current contracts expire on the 31st of March next year. So this recommission is only for the care and support. Some of the schemes that you may well know from your communities are ageing, but that's a different conversation. That will need to be a piece of work that takes place with landlords over the next 3, 5, 10 years as to what happens with those sites. This is just about the care and support we're providing into those schemes. So in terms of where does it sit on a continuum, and this is really simplistic. So as we've heard earlier on, there's people living in mainstream housing that can have a really significant package of care. But it all depends on individual circumstances. So if you think of it as a continuum around level of independence and cost of the council, you've got nursing care at the very, very top end, and then residential care, and then preceding that, extra care housing and supported living, which are similar services with different groups of people. So that's the kind of continuum everything sits on. But I thought it'd be helpful to illustrate that Victoria in terms of thinking about where extra care housing sits and the types of service we commission. So in terms of our outcome, what we want to do is to use extra care housing to reduce the council's relative use of residential care during the lifetime of the contract. So that's not to say we want everyone who we would look at for a residential care package to be supported in extra care. That's not going to work. There are people that need a level of restriction or a level of support that can be supported in a residential care environment. But there's also some, for example, people where it's not been practical to support them overnight in their home environment, where extra care can provide that environment where someone can access overnight support through that 24/7 staffing on site, and that enables them to live in an extra care scheme in their community rather than moving into a residential care. We've done a piece of work recently with Newton where they've looked at recent new packages of residential care, and what we found is around, with the right adjustments, around 16% of those placements we could be looking at an extra care housing placement instead. So it needs to be seen as it's one of the approaches we need to take, not a panacea. As part of the work we've been doing, we visited every scheme in Somerset and met with tenants. We offered them the opportunity to do that in whatever way they wanted. With some tenants, we met them in a group in the communal room. With others, we met them individually. In one of the schemes I went to, we had about a dozen people who wanted us to go and visit them in their own tenancies, and we took that approach and collated the feedback we had from them. We've also had meetings with every landlord to discuss the proposals that we're making. We've sent a survey out to all town support staff. That's coming back at the moment and being collated. And we've also undertaken meetings with other councils to understand how extra care housing model works within their area. And interestingly, most of the councils we've spoken to have been in the process of looking at recommissioning their services, but at different stages. Some are ahead of us, some are behind us. And we've also been reviewing our service specifications in terms of conditions for extra care housing. So in terms of our key proposals for the recommission, what we want to do, and this was one of the main things we landlords today, was to increase the overall level and range of need that can be supported in extra care housing and to continue to develop it over the lifetime of the contract. We're not saying that on the 1st of April next year, everything will change on that day. It can't, because there are people already living in tenancies. This is about slowly, as new people move in, enabling the schemes to be able to support people at a higher level of need. And as part of that, what we would want to introduce is the ability to step up and step down the delivery of care and support overnight in order to enable people to remain within an extra care housing scheme, and if they have a level of night need that might, in the past, have meant that we looked at a different type of service. One of the other things we've been looking at is bringing consistency. The arrangements for extra care were different from each predecessor council patch. Sometimes the differences were small, sometimes they were quite large. So what we're trying to do is bring in a consistent charging policy for extra care housing as part of the process, a consistent allocation process, and that allocation process will be jointly between the council, the care provider, and the landlord. And what we're also looking at is consistent arrangements around the delivery of housing-related support. So that's helped for people to maintain their tenancies. At the moment, we have two different models. One is that it's provided by the care provider, the other where it's provided by the landlord. One of the conversations we're having with landlords is our preference would be for it to be provided by the landlord because they are the experts in tenancy management. And that's an ongoing conversation we're having at the moment. Another change we're looking to make is for all the fees and charges to be looked at as part of the annual and also care fees and charges process. At the moment, it's not incorporated into it, it takes place outside of it. We think it would be better to do it as part of that. We're updating all our service specifications. As I've said, our contract terms and conditions need to be brought up to date. The contracts were last let in 2015-16. We've not only learned a lot since then, but we're working under a procurement regime that's coming in from October, and we're also working in a very different environment post-pandemic than we were when those contracts were first let. So we need to make sure they're brought up to the same level as other contracts that have recently been there. We want to introduce a consistent three-way agreement between landlords, care providers and the council. At the moment, we have a variety of different agreements. We need consistency in order to make that work properly. And we're proposing to tender the contracts for the care and support as 3 separate lots. The reason we're looking at 3 rather than a different number is that in the east of the county there is only 1 scheme, and we felt that if we put that out as a single scheme lot, that possibly wouldn't be attractive to the market. So we've merged the east and the south of the county together, and then the west and the north are individual lots. And one of the things we've done is asked tenant representatives if they'd like to be involved in the tender process. And what we want to do is ask them to write and evaluate a question as part of the tender process. So in terms of next steps, our plan is to undertake a 2-stage procurement process and for the executive to consider the outcome of this in December. The draft timetable at the moment is that we'll launch the first stage at the beginning of August, we'll launch the second stage at the beginning of September, and the deadline of the final submissions will be the beginning of October. There's then around a month's period to evaluate the submissions, and then the governance period between that evaluation and going to the executive in December. And then, because we would expect 2 people to apply, we have allowed a 3-month implementation period up to the contract start date, so the 1st of April.
Very much. It's very, very clear, actually. I think if you, sorry, you had finished.
Yes,
sorry, I apologise. You looked at me as if to say, "This is it, Joe." So, sorry. So, does anybody have any questions, please? About Councillor Woods.
Sorry to be quite thick, but how do I recognise an extra care house? Because we have these, it used to be under Magna, and suddenly some tenants aren't getting care, some tenants are. Are they extra care houses?
We've got 14 schemes in the county. I'd be happy to share the list of schemes with you so you would know which ones they were.
Please, you can send that. Yeah.
I can do that in a minute.
If you could send that to all of us, I think that might be good. Not that we necessarily need to identify, but it'd be nice to know where they are.
Absolutely.
Do you know what I mean? That would be really good. Thank you very much. Does anybody else have Councillor Lawrence?
Extra care housing is something I really appreciate because I've got a very good setup in my area and they do a fantastic job at giving people freedom that can go out a little bit, shop and get to see their friends, and those that really can't. But there's a great sense of belonging, and friendliness, and not being on your own. So it's not perfect by a lot because they don't have a big room or a flat. It's a small room with a necessary toilet and bathroom and the rest of it. But on the other hand, they are not lonely. Certainly not as lonely as they would be if they were living by themselves. So I think there's great value in them personally, and I would want to keep them as long as possible because there's ever increasing numbers of people that actually aren't safe to be on their own.
And I think we're all going to average age out now soon to 110. So we want to be able to live in nice, comfortable places. Looking at Mel's looking absolutely horrified. I've not got children for another 40 years, but but can I just ask you, is the cost in line with natural costs? Is it very much more expensive? I just wanted to know to live in that environment.
The cost. Do you mean the cost of the council?
well, the cost of the home living in there.
To an individual. To the individual. So the individual has a tenancy, and the tenancy is in line with local rates, but they also have service charges on top of it. So it depends on the scheme as to what the service charge includes in it. Some of the schemes include meals. So one of the things we want to make sure is very clear with landlords is that they make what's part of the package when people move in absolutely crystal clear. I'm not saying that's not the case now, but as part of making sure that we've got an arrangement that's fit for the future, we're making that absolutely fit. So some schemes it's very little extra. Some schemes there's quite a lot extra with a hot meal every day, for example.
I'm just going to Mel.
So where we are, and if we get our housing strategy right for the future, what we'll be able to say is what do we need for the next 30 years, and extra care will be part of that. Some of our extra care is not modern enough for us for the future, and it just isn't. But actually, it's not just about extra care, is it? Some of you will say, and I'll use McCarthy Stone because that's an easy one, but there are lots of other organisations out there. I know you don't like them, but that's lying. And there are lots of other ways of getting retirement flats for people. So these ones tend to be on you don't tend to be able to buy into those leases. And I think going forward, we need to think about, is there a mixed economy that will stack up so that our extra care is okay? So can somebody buy? Can some be rented? And I think that's the future. So over the next year, you'll be able to start to see actually what do we need in Somerset for the next 30 years? What does that need to look like? And then we can work with our landlords, with others to say what are our schemes. So this is the first step to say, let's get it right for now. And then we work along, okay, what's the art of the possible? What do we do for the future?
Thank you. You said about the contracts finishing, you said about you going to executive. Do you need our endorsement as a committee?
Obviously, the decision paper will come round in the normal way. And one of the questions I was going to ask you later in the year is how you would like to be involved in that. Would you want us to come back again, or would you be happy having sight of the decision paper when it's finished?
How does the committee feel?
I think it'd be very useful. This is a big move. I think I would be very comfortable for him to come back again. I think this is a very important piece of work.
I think what we like to do as well is we don't like after, we like before. We always think about the preparation, because I think we like to be on the front foot, not the back foot. So if it's not too bad, even giving us a briefing, letting us know, but any endorsement you need, I think you've got it in the committee. Thank you. Councillor Bruce.
Thanks, Chair. Could you give me a bit more information about the introducing the ability to step up and step down delivery of care overnight? Can you sort of elaborate on that a little bit? Are these housing, are they going to be sort of connected with individual care homes? Have they got somewhere already where they can directly go? How does that work overnight?
At the moment, every scheme has staff on site 24/7, but some of the majority is sleeping. There's only a small number of schemes in Somerset where there is a waking night in place. So in order for someone to receive regular care overnight, we would need waking nights in place. And at the moment, those arrangements aren't in place for those in the majority of the schemes. What we want to do is have the ability to step up a waking night if the level of need of individuals on the scheme requires it. But if that level of need drops, we can then step that night back down to sleeping, so the person is only woken when and goes to support people if someone presses their full bell or something.
Thank you once again. Thank you once again, Steve, for coming today. I really do appreciate this. We obviously, as you can tell, we would like you to come back. We like you, so therefore we'd like you to come back and let us know how things are going and progressing. And obviously, before it goes to the exec, that would be really great if there's a possibility of that.
I'll work out the time scale.
Thank you very much. Thank you for coming today. Thank you. Members, right, the next item, just to let you, is item 11. This is a consultation on the draft Somerset Suicide Prevention Strategy, which is item 11, pages 181 and 208. This is a very difficult subject. We all know it's a very sensitive subject, and I want members to use your knowledge but I don't need you to relive your personal circumstances, because this is a very sensitive, and I don't want people, we need to be listening to this and knowing how things are going. So I hope members are happy to stay. Any members who feel or officers feel they do not want to stay, I do appreciate that. If you wish to leave, that is entirely up to you. Okay, thank you. So I'm now going to invite Amy Hardwick and Matthew Hibbett, Andrew Keith and Andy Pritchard. So you're going to do a foursome, I think, is it? Or, no, that's not the right word, sorry. You're going to do you're going to do a double, whatever. Well, you're going to do something, all right?
Thank you, Chair. Yes, thank you. I'm just going to say a few words of introduction. Amy and Andy are in the room, and myself and Andrew Keefe are online. I was just going to say, by way of introduction, this is an item that has been here before. So I think we came at the beginning of 2023, so beginning of last year, to talk about the developing suicide prevention strategy. Since then, we've seen the publication of the national strategy, which was in autumn last year, and we are now in process of finalising our local strategy. So I know that we're pressed for time. I think Amy is going to run through the slides that we've got, and there is an opportunity, obviously, for members to ask any questions of any of us at the end. So, Amy, I'll hand over to you.
Thank you very much, Matthew. I'm slightly concerned for some reason the graph on this slide doesn't seem to be showing up. You did get the slides beforehand, so I don't know whether you can see them in that set. I'm not sure why it's not coming up. Should I try sharing again, or should I just talk?
I think we've got them. We've got them in our pack.
You've got them in your pack. Yeah.
I believe we have got everything in our pack. I don't think there's. We've got different graphs.
Blue honeycomb shapes.
Yeah, we've got those.
Yeah, we've got all that. So yeah.
We haven't managed down this morning, so you're doing well.
Thank you very much. Okay, so as you know, we came along to Scrutiny last January, and we were awaiting the National Suicide Prevention Strategy, which was published in September last year. Since then, Public Health has led the co-production of our local suicide prevention strategy in partnership with our colleagues in the ICB, the NHS and the voluntary sector. Our local suicide prevention strategy is based around the 8 strategic priorities that are laid out within the national strategy. And we've developed our own objectives to show how we're going to meet each of those priority areas. And we'll be producing annual action plans to support the delivery of the strategy, and we'll provide annual reports which will demonstrate our progress towards each of the objectives. Obviously, the main aim of the suicide prevention strategy is to reduce the number of lives lost to suicide in Somerset. In 2022, there were 45 deaths in our county to people by suicide. But we did see the first reduction in the suicide rate that we've seen since 2014. So it reduced from 14.8 to 12.7, which is a positive move that we hope is going to continue, going by the data that we've got from our real-time surveillance for this year as well. So the strategy is broken up into these 3 overarching aims. So the first of those is that top honeycomb structure. That's my terrible maths, not sure what shape that is. Which is around the data and evidence, and using this information, both local and national information, to inform our suicide prevention activities and the interventions that we provide locally to reduce the number of deaths by suicide. The second one is around the engagement with public and professionals, and how we can share that message that suicide prevention really is everybody's business. And something that we all play a part in, and a main vehicle for that is through the Orange Button Community Awareness Scheme. And the third one is around evaluating the services that we do have around crisis support and our suicide bereavement services, to make sure that they are meeting the needs of our population, and that they're providing that impact, and that they're sustainable also. So I know you will have looked at the document, and so you will have seen the strategic priorities in there, but just to show that these are the 8 strategic priorities that are set out in the national strategy and that we've adopted in our local strategy also. So they really do link together, you know, improving the data and evidence. We need that data and evidence to be able to provide targeted and tailored support to those priority groups. We need to know who those people are, and we'll get that from the data and evidence from local services and from the data we get around deaths. We'll also be able to use that information to address those common risk factors at a population level. And also around reducing access to means and methods of suicide. Again, we get that information in the data, and it's only by utilising that we can understand how people are taking their lives and try and prevent that. There's 2 in there about providing effective support. So that's the crisis support and the effective suicide bereavement support, because we know that suicide bereavement support is also very important in suicide prevention, as people that have been bereaved by suicide are at an increased risk of taking their own lives too. And there's one there also around promoting online safety and responsible media content to reduce harms and making suicide everybody's business. So that's really that part about engaging with everybody in our community, and making sure that we all know that we have a role to play in and knowing what we can do to try and reduce the number of lives lost. So I'll just go on now to our suggested priority areas for action. This is for our first year. So the action plans will run from September to September. So we are going to be doing a public consultation on the strategy also, which will be going live in the next couple of weeks. That will be live for 6 weeks. And then we'll have a couple of weeks to look at that, and then aim to publish the strategy on the 10th of September, which is World Suicide Prevention Day. So our areas for action are broken up into those 3 overarching aims. So in data and evidence, we've got an action around creating an information sharing agreement that will help us to share information between services about individuals, and enable us to really track those people's journeys prior to their death to understand where we could have intervened sooner. We also want to establish a process for learning from suicides and suicide attempts. We know that for every life lost to suicide, there's another 20 people that do attempt to take their lives. And at the moment, we don't have access to that information. And that's really important in terms of prevention, because we don't have lots of deaths by suicide, thankfully. But that means that we have very little data to go on. So to increase that data, we can look at those suicide attempts and learn from those to help in our prevention activities. The second one is around engagement. So the main vehicle for doing this is through the development of a suicide prevention pledge. This will be a pledge that can be signed up to by individuals and by organisations. And it will include a commitment to completing suicide prevention training and signing up to the Orange Button scheme and having a certain number of Orange Button holders within organisations to make sure that there are people available to talk to that have had training and know where people can get support. And obviously we'll need to do some publicising for that pledge. And then finally, around the evaluation of those services. So we know that the crisis services that we got, so Crisis Safe Space, I know, Andy, you've shared some of the leaflets for that service that's provided by the voluntary sector. And we've also had the addition of the mental health ambulance recently, all of which, you know, have helped to reduce the number of A&E admissions for people who have self-harmed or attempted suicide. And we want to use this evaluation information to understand how these services are meeting the needs of our population and where there might be gaps where we can address those through our suicide prevention activities. So make sure that we've really got that kind of cyclical feedback of information at each point in people's journeys. That's it. Obviously, you've all had the document as well.
Yeah. Can I thank you for the documentation and the slides, because it's a very difficult document and a lot of info in there, a lot of information. The one thing I'd like to start off is that I have heard of this before, that the rate in Somerset has generally been slightly higher than in the rest of England. And it's averaging at one a week. Now, recently we've had the M5 issues, and we all know about that. We've all been incredibly sad. Can I ask why you think it is in some? Do you have any data to prove why? Is it just circumstance? You know, do you have any idea?
I wish we did, but there isn't anything that we can identify in the data that we have at the minute that could show what it is about, you know, Somerset, the reasons why we've seen a higher rate. But I do think it is positive that we have seen a reduction in that rate for the first time since 2014. It has been sort of gradually going up since 2014, and we've now seen a reduction, and hopefully that will continue.
What I'd like to ask as well is that as councillors, we see lots of people, probably more than average people, and sometimes you identify with somebody who's perhaps you don't think is perhaps doing too well. And I know you used to have little cards once before you gave out little things. Yes, that's right, yeah. And I think that's really good to have that you can give to somebody. And I just wondered, are you still doing that kind of work? You clearly are, but.
Yeah, definitely. So with the Orange Button scheme, that's all about training people up to be able to have the confidence to have those conversations. Suicide prevention, it really is something that we all can do. It starts with a conversation and people having that confidence to ask that question directly to someone if they're thinking about suicide. It's the kind of the fear and the stigma that surrounds suicide that stops people from talking about it. And that's one of the biggest barriers to people accessing the support that they need. So that's why we're really, you know, pushing the suicide prevention training that we've got. You know, we've got the applied skills in suicide intervention training, the assist course, and the Every Life Matters training that we've now trained up members within public health to deliver locally as well, which gives people those skills and gives people the confidence to start those conversations. And we've also, we're currently developing some conversation cards, again, to help people have the confidence to start those conversations. And that'll list, you know, all of the support that we've got available locally on there as well. And yeah,
it's good that it's physical, because I'll be honest with you, when you talk to people and you say there's stuff online, you can read about it. People in that mode aren't going to bother with that, but something like that would just tell people, give them a link, give them an idea. Andy.
I guess I passed around some of the cards, and there's some other selections because I didn't have enough to give everyone, but some of the things we're doing. So, for example, some of you've got the crisis safe space, so that's a significant change that people can go in person as well and meet somebody on that day. So we're really looking at the whole offer across the system. So the Open Mental Health Partnership with NHS and voluntary sector, that's also meant that Mindline is now getting out there. You've got that 24/7 service. More and more people are hearing about that. But then it's those add-on bits to the system, such as the crisis safe space, the community training, and the orange button that Amy's been talking about. And we've also got cards for the Somerset Suicide Bereavement Support Service as well. So just having that information, you're right. This is one of those areas where we find having it in hard copy is really important.
Absolutely, absolutely. Members, is there anything that you'd like to ask or any comment you'd like to make? Anyone? Oh, Graham, sorry.
I was in a motorway service station. I was having a wee, and in front of me was a thing about if you're being held there against you, call for Angela sort of thing. And I thought, well, never been in that position. But I do think there needs to be a kind of equivalence. There needs to be a way for men to come forward in a way that doesn't end up with a mental health record or stigma in any way. Something, a range of ways, because we're all different. We've looked at housing and the varieties there, but we need more ways in which, for that individual, there's something that allows them safely to express how they feel. And you're going to really have a struggle, because us men don't like talking about feelings. We don't have them really, so we're told them. So it's very hard to express, and those thoughts are not ones you're proud of and not ones you want to share. So you've got an incredible challenge, but I do think the solution will lie in a whole sift. You need like 30 different doors. Sorry.
So thank you, Graham. So Public Health do commission actually through Open Mental Health something called Step Ladder, and it's exactly that. So it's a space where men come together to talk about the initiatives that have helped them, and it's exactly that. It's about supporting lots of different initiatives because there's a real recognition with that cohort. It's having different solutions and being able to offer those in different ways, and that's working with a range of different stakeholders to provide that. So we are trying to address that particular need as well.
Thank you. Amy. Oh, sorry, Amy. Sorry, I'm looking at another.
That's okay. I just want to say it is a challenge because we're trying to change it's the culture, and that takes a long time, but it starts with us. You know, we all can change that. We can challenge the stigma. We can be willing to start those conversations. We can be willing to say the word suicide and not have that fear around it. You're not going to put the idea in someone's head. You know, if you ask them about suicide, if they're not already thinking about it, they'll just say, oh no, it's not that bad. You know, but if they are, then if you say them and you ask them, if you say it to them directly, and they can then open up to you and they know that it's safe to share those thoughts, because it's scary. It's so scary to be in that position where you're choosing between living and dying. And so, you know, it's a scary position for them than it is for you to ask that question. And that's the message that we want to share, you know, and that's what we're going to try and do, you know, with the pledge as well. You know, it starts with all of us and we can all make a difference.
The sadness of the M5 actually brought us all talking about it. And a lot of people have talked about it a lot since then. Some people have got harsh ideas. Other people have said, hang on a minute. But I've noticed it's, even if you go out socially, a lot of people have been talking about it. A lot of people have been saying how awful that was. Second time, that person must be in it. And I know that was sad, but out of that may come some good, that people perhaps get a better understanding, perhaps a better empathy, perhaps a better awareness. And when somebody's down, are they really down, or are they, you know, how bad are they? And I think I'm hoping that some good will come out of that. Fortunately, they managed to get him and save him, and hopefully he'll get the treatment he needs. But you know, it's a very difficult job. Do you have a big team of you? How big is your team?
It's me and Matthew, and obviously the other members of the Suicide Prevention Partnership. So it's very much a team effort, particularly around suicide prevention. So although it's sort of just myself and Matthew in public health, we do also have Jack, who leads on the kind of data and evidence side of things, and yeah, Andy and Andrew online.
Well, I ought to ask the other. Does anybody online? What was his name? Sorry.
Andrew.
Do you wish to say anything? Sorry.
No, not a problem at all. I'm Andrew Keefe from the Somerset ICB, and I think you're right to raise a question about the capacity of the public health team and the wider team. I think it is a small group of people who, particularly both Andy and Amy has demonstrated, are very, very passionate about what they do and exceptionally competent in it. And I think disproportionately have a much bigger impact than the size of the team themselves, and all credit to them in pulling the strategy together. It was led by public health, but their engagement is very, very wide, including the ICB, including the Trust, and especially the VCSE partners that are there. Also, just to note that the rates of suicide have stabilised and falling, and yet Andy will attest to Mindline, the number of calls that they're receiving and the demand on mental health services are significantly increasing against a backdrop of financial pressures that I don't need to inform the council about. And so it is remarkable. And if it weren't for the services that are currently being provided, I think the rates will be significantly higher. And the problem is, too often the data that we use is the data where people have been successful in terms of taking their own life. We can only count the people who take their own life. We have no way of counting the numbers of people who have had a successful intervention, be that from Mindline, be that from a colleague, be that from a family friend. All those conversations all cumulatively have a positive impact, but it's very difficult to measure. And we emphasize too much in terms of suicide prevention, the word suicide, and not enough in the word prevention, and how many lives actually have been saved. we can't possibly know. But I'm assured that that's a very, very significant number through the great efforts that have currently been delivered in Somerset.
Thank you. And actually, it would be good if we had that data. How good it would be for people to actually realise how many people are saved, how many people took. I don't know how you would do that. I get that, but in a way, it would be really good for us to quantify that somebody who's thinking on that lines remembers all the people that actually went and sought help when they came through. And maybe there's a way through that you may find some.
I hope so.
Yeah. Well, I wish you all the very, very best. Oh, sorry, Councillor Bruce.
Thanks, Chair. Obviously, it's important to get people talking, and that's quite a big barrier. That first step of getting someone to talk, but it's really important we've got the services after to pick up. So I think we've still got work to do to improve our mental health services and capacity. I've had quite a few people, this is more an observation, say to me in the past that, especially for young people through CAMS and things, you've got to have actually attempted suicide to get help. I've had that comment a couple of times. So I just wanted to say I'm really pleased to see that focus on the prevention now. And I think that's really important. I just want to welcome it. Thank you.
Yeah. Andrew, would you like to come back, please?
Yeah, just to pick up on that and the specific point around CAMS, I think historically, sadly, that was the case. And there was strict adherence going back 5 or more years, where the criteria was very, very strict. That isn't the case now. Nobody is turned away from CAMS, and CAMS itself is now rated as outstanding and is one of the regional and national leaders in terms of CAMS. But historically, it is we have one single point of access now for all mental health provision, be it by the trust or by VCSE partners such as Young Somerset, who are also very, very active in this space.
I think, Andy, it's also been very difficult in the past to get an appointment with CAMS. And I think that's been the biggest thing. That I know young people, families are trying to get their children to get an appointment. That's been very difficult. So, Andy Pritchard, sorry, second Andy.
So just to say, so we've talked about the crisis safe space. There is a pilot at the moment for a youth safe space as well. So recognising that need, albeit it is unfunded at the moment. I'd be remiss of me not to make that point, but it's there.
Well, that's good that you mentioned it here. Portfolio Help just taken that on board, so that'll be really good. So, where is it?
So that's operating out of Yeovil and Taunton. So a part of this was being in proximity to A&E, because we recognise that's often the space that young people are directed to, but often if there isn't actually a physical need at that point, not always the best place for a young person to be. So operating out of Yeovil and Taunton, actually, they're both at the Mind hubs in Taunton and Yeovil specifically. I can send more details through if people are interested.
Amy?
Sorry, just one more thing. We do have the mental health support in schools teams as well. And I know they're not in every school, but the aim is, for that to be the case. And Somerset is doing really well in terms of training senior mental health leads. We've got above kind of the average numbers of people going through that training all the time, so that there are people in schools that young people can talk to that have had that training too.
And I think that's vitally important that it's in our schools. I think it should be in every school. And I think, Graham, did you want to say something? I can hear you.
I was just thinking Yeovil Town Council and Taunton Town Council may well be worth an approach for a grant.
Any town council, in fact, any town
that's
council.
What they are, so.
Yeah, but what I'm saying is you need to be wider. So if you want to come into Bridgewater Town Council, anywhere at all, I'm sure you'd be welcome. So can I just thank you today for coming today? Sorry that you're last on the list, but you're vitally important, and we value it. And we'd like if we can, maybe you could come back again or give us a briefing within 6 months. I think it'd be really good for us to know how progress is made, how things are moving, how you're doing. It would be really good to have you back if that would be okay. All right, yeah, definitely. Thank you. Thank you very much. Members, there is another item just to explain to you. There is we need to discuss whether we're going to. There is a new model of care. And what it would be really good is if we could have a focus group, the old workshop, whatever, I like to call it a focus group, and whether we can have a focus group to know exactly how the care is going, what's within that, so we have a better understanding of the process at the moment. Now, we can do this on Teams. It has been said we can do this on Teams because I do appreciate some members' work, some members' locality, everything else. Just want to know your thoughts on it, please. We were thinking about September.
Yeah, I'm quite happy to do it on Teams. Be happy to participate. Teams is much easier for me for working, fitting around my working days. That'd be great.
I thought, yeah, that's what I thought. I know it's nice for us to meet up together, but I think Mel said that was okay on Teams, didn't he? Yeah. So I think we'll organise that then for September, okay? And we'll do it for Teams. But we will, you know, because we're meeting again in October. So it's not like we're not seeing each other, but what I'm thinking is we'll probably get more participation if perhaps on that kind of thing. And we'll learn a lot more about the new model, which is what we do need to know exactly how things are progressing. Okay.
Sure.
Thank you, Mel.
So just to clarify, it's the ICB's health and care plan is what they wanted to come and talk to you about. So it's their strategy and their health and care plan. What they wanted to do was have that conversation with you in a group, focus group, so that actually then you can say, actually in this we'd like to have more depth in this. So it's a starting point for us then to be able to explore with them and with us, actually, can we bring these bits back, or can we think about this, or if something's going wrong in this area, how do you pull somebody in pretty quickly? So it's a bit of that two-way conversation to understand what the health and care strategy is about, and do it in that way.
Did they want a formal meeting then? Sorry.
No. They're happy to do a. They want to do more than happy.
Oh, okay,
They were
that's
happy
fine.
about this idea, but it does still want members to know.
Yes.
Scrutiny is live,
Yeah.
so it's ever moving. We do a forward plan and then we find something else comes up that comes in. So don't be afraid. It's not stifling. It's just giving us a much more in depth into things. Okay, Hilary?
Yeah, so just to clarify though, this focus group is working with the ICB in terms of setting some key questions that we want them to come back to the whole committee with. Yeah. Okay.
Okay. All right then. Thank you so much for today, and I declare the meeting closed. Thank you.